Good evening, everyone, and thanks to Bhargav and Sriharsha for organizing this. I really have to give you a lot of credit for making this as an educational meeting and a recurring meeting as possible. Doing a couple of these is of course creditable, but doing it multiple times a week is something that's extremely creditable indeed. So thank you for doing that, and thank you, friends, for having me over. I hope we're able to make over the course of the next 2 days, Bhargav and Sriharsha, and I think a couple of our prodigies from the past at Patel Hospital. They wanted us to speak on controversies in thyroid surgery and DTC. For the most part, we're going to talk about cancer, but we'll also talk about thyroid surgery. So we'll talk about workup and initial management of a thyroid nodule, and we'll move that on to primary management of DTC. Talk a little bit about the neck, only the controversial part, as the organizers want us to do, and then take it on to talk a little bit more outside of the box in terms of invasive thyroid cancer, and also taking it further in terms of parathyroid preservation. Okay. Bhargav, the slides are displaying adequately, I hope.
Yes, sir.
Okay, great. So in the 15-20 minute slot that we have for thyroid nodule, do remember that all of your participants are more than free to ask me for a PDF of this presentation, and we'll be sharing that with them. We know that thyroid nodules are a problem, and we know that as per data by the ITS, roughly 5% of our population is already affected with thyroid disorders. That might or might not be nodules, includes nodules, of course, but also includes a lot of neoplasms that we encounter on a day-to-day basis. When we talk about the West, we of course talk about why to evaluate a nodule to the extent that we do. It's because there is a perceived increase in thyroid cancers, and some of them call it a false increase, but we can't really deny the fact that we are diagnosing more of these cancers, and there is a survival curve associated with the same. When we talk about nodules per se, we know that about 1 in 15 females and about 1 in 50 males do have nodules. The autopsy incidence of nodules is kind of on the lines of prostate pathology. You find them in a lot of patients. You can detect non-palpable nodules on ultrasound or on other anatomical imaging studies, which are known as the true incidentalomas. Generally, however, it's important for the new trainees in the group that only nodules more than 1 centimeter should be evaluated, because they have a greater potential to cause clinical as well as oncological outcomes. Sometimes you might require evaluation of nodules less than 1 centimeter, and that's usually when you have clinical symptoms or associated lymphadenopathy. When we talk about nodules and when we talk about thyroid cancer, of course, they go hand in hand. The ATA itself clubs the management of thyroid nodules and differentiated thyroid cancer together, and there is an etiology associated with them. Based on that, we know that we have certain high-risk nodules, which are displayed here, and certain low-risk nodules, which are displayed here. So when you pick up a nodule and you're uncertain about what way this is going and what chance does it predispose to an individual developing cancer, we need to make sure that we have some kind of an algorithm in mind, and we'll talk a little bit about it as we go along. Of course, on the right are the symptoms that can alert you. If a nodule has any of these symptoms, you're more concerned about it being a cancer. But of course, all of us know that workup is usually selective and judicious application of the following investigations: FNA, ultrasonography, thyroid function tests, CT scans, genetic testing, very limited, but yes, increasing in relevance with time, CTs, MRs, and PET for cross-sectional and scintigraphic images, and in select cases, a core biopsy. We'll keep it limited to the top 3 or 4 for the purpose of this discussion, because we want to send out a basic message to a lot of the attendees, as well as stimulate the minds of a lot of budding oncologists or currently practicing oncologists in terms of how to apply this to really stratify a nodule with respect to what we have. So coming to FNA, which forms the initial investigation of choice in any thyroid nodule. It is the procedure of choice. The sensitivity and specificity are wide-ranging. It's a cost-effective and a minimally invasive technique. We know that sometimes we might have to do a repeat FNA. There are caveats to an FNA as well, as have been listed over here. It's sometimes difficult to get to that posteriorly located nodule, especially for someone who does not do interventional radiology that often. We also know that sometimes a small minority of these patients might actually have malignant change, and some of them might not. And we know that adjacent vascular structures can be a caveat. So you really want to be absolutely sure. In case an FNA has been done, always do it with ultrasound guidance. It's important that we do it. And the reasons at the bottom are primarily the reason why we advocate ultrasound guidance for any FNA a thyroid nodule. So that's a take home that's important to know, especially for the young physicians. How do we interpret this? There is the Bethesda system that you're comfortable that you are familiar with. Now there's modified Bethesda systems also, and other systems as well. But the original Bethesda system still holds good. There are 6 categories. There are now subcategories as well, and we divide them from 1 to 6 based on their predisposition to malignancy in terms of what the pathologist sees. Remember, there's also something called adequacy of sampling. There should be a minimum of 6 follicular cell clusters with at least 10 cells each for any cytopathologist to actually call it an adequate sample. So yes, specimen adequacy is important. And why is it important? Is because there's a significant category of patients who will end up with something called Bethesda 1. If you do a Bethesda 1, or if you get a non-diagnostic or unsatisfactory sampling, typically you end up repeating it. If the initial FNA was not done at your center and the patient presents to you, always get it repeated with ultrasound guidance again. We've talked about that, of course. If there are repeatedly non-diagnostic nodules, but with low suspicion radiology, and we'll talk about radiology in a bit, they warrant close observation. Some patients, especially the patients who anticipated will be non-compliant, will sometimes get a surgical excision. But of course, the line at the bottom is something that's important. You should consider surgery if the sonography is more concerning. So you really try to get both instruments together, cytology and radiology, to help you get a complete picture. If you have a growth in the nodule, which is more than 20% in 2 dimensions, or if you have any of the clinical risk features of malignancy, in those cases, you should offer surgery for non-diagnostic pathology as well. Guidelines typically state 3 Bethesda 1 samples, or 3 Bethesda 1s would be adequate for you to actually offer surgical excision. But it's important to know that in certain scenarios, you might want to intervene after 1 or 2, especially if any of these high-risk features are there. Let's get to Bethesda 2, because we'll discuss FNA in some detail. If Bethesda 2 has multiple subcategories, if you have colloid goiter, hyperplastic, or adenomatoid goiter, you don't really need any further diagnostic studies. Interesting analysis, pooled analysis of 12 studies for more than 4,000 patients with benign cytology who eventually underwent surgery. Even though most of us in our contemporary practices would not offer surgery a lot to Bethesda 2, the rate of malignancy was only 3%, which kind of agrees with what we read about. However, there are some instances in which Bethesda 2 nodules would also need surgery. Pressure symptoms are a given. So dysphagia, dyspnea, and dysphonia typically will warrant, and of course, the dysphagia, dyspnea, or dysphonia, or the compressive symptoms should be attributable to the nodule per se. If there's a hemorrhage or a cystic change in a nodule which causes pressure symptoms, you typically intervene even in a Bethesda 2 nodule. If there are cosmetic indications or there is functional hypertrophy. Remember that if the nodule is asymptomatic, however, which demonstrates a very modest growth pattern, which is less than 20% in 2 dimensions, you can typically just follow them without intervention. There's some interesting literature, especially from Europe, on percutaneous ethanol injection for these nodules. But for the most part, I'd advise you to stick to the things that we've already mentioned. Ethanol injection, especially in the absence of reliable follow-up for a vast majority of our patients, is something I'd take with a pinch of salt. So intervene the ones which have no compressive symptoms and a modest growth pattern. Intervene in the ones which have high suspicion clinical symptoms, the signs that we discussed, as well as rapid growth pattern. There is a role, or there used to be a role, I would say, for medical therapy for benign thyroid nodules. So Bethesda 2 nodules, which you might want to treat medically. But remember, routine TSH suppression therapy is not recommended in the present day. All of us have done it in the past, as recently as a few years back. But why it's not is you don't really want to cause iatrogenic thyrotoxicosis. It has multiple issues associated with it. The potential harm outweighs the benefit for most patients. Cardiac arrhythmias, osteoporosis, and iatrogenic thyrotoxicosis can be problems, which you don't really want to tackle, especially for a patient who has had multiple Bethesda 2 FNA reports, which would probably not be able to justify the risks associated with putting them on high-dose Altroxin and therein going in. Molecular testing is, for the most part, a question that we encounter in Bethesda 3 and 4 nodules. Broadly speaking, there is something called rule-in testing and rule-out testing. Remember that if we are intending it for clinical use, Afirma, which is the 7-gene panel, the rule-out test, is currently available in India. There are cost implications and resource implications, but yes, we've done it for a couple of our patients, and you should know that the option is out there. Molecular testing, especially with some other rule-in tests like the Thyroid and the Thyroid, have actually shown much more promise than the Afirma, which is actually a gene expression classifier and is a rule-out test. But knowing that, that's one of the very few options currently available in India. The turnaround time is a couple of months, and the cost is a couple of lakhs as well. Remember that molecular testing has been recommended as being performed in laboratories which are certified, and that's important before you even start discussing this option with your patients. What mutations do we test for are the ones listed at the top. You really want to rule out differentiated thyroid cancer, and that's primarily the entity that you want to rule out in a patient who is presenting to you with a symptomatic or an asymptomatic thyroid nodule. Remember, like we talked about, this lines at the bottom, it does not significantly aid decision making. So yes, it adds a little bit to the sensitivity and the specificity of an FNA, but by no means is it a complete clincher. And there are cost and resource constraints, of course. Talking about Bethesda 3, 4, and 5, by and large, you discussion with your patient and their caregivers about the benefit caveat for him. I see some faculty in the box here. In most of our hands, a hemithyroidectomy would be a fairly safe procedure, and it is something which we would tend to offer to our patients with Bethesda 3, 4, or 5 nodules. Sometimes the extent of surgery for this subcategory of patients might be modified. Recommendation 25 of the ATA guidelines states those guidelines pretty eloquently. If you have large tumors, you might tend to offer them slightly more than a hemithyroidectomy, which of course would be a total. When marked atypia is seen on either an FNA or a core biopsy, when a biopsy reading is suspicious for papillary, which actually is a Bethesda 5, patients with a family history or a history of radiation exposure, there is a recommendation rating that's fairly high. So for these subcategory of patients, you might offer a total thyroidectomy despite the absence of confirmed disease in terms of a Bethesda 6 report. So do remember that. So if we try to sum up Bethesda and stopping short of malignancy, which we'll be talking about shortly, these are the subcategories that we know. We know that the incidence is as is mentioned over here. Most of our FNAs are going to be benign. The risk of malignancy in Bethesda 2 is less, and the usual management has also been outlined. And for the organizers as well as the attendees, I'll be happy to share the PDF with anyone who's interested. So I'll skip over it in the interest of time. Bethesda, of course, is not the only tool over there. There's the British Thyroid Association classification as well, which divides it into THY for thyroid 1, 1C, 2, 2C, 3A, 3F, 4, and 5, which essentially is a surrogate of Bethesda 1 to 6, broadly with the same categories, and knowing that yes, the information that you're going to get from cytology, provided that the specimen is adequate and the sampling has been done appropriately, will be able to help us guide us towards the diagnosis. So, fine needle aspiration is the initial standard investigation of choice in a thyroid nodule, solitary or multiple, and is usually employed to the effect of what we spoke about. But usually, fine needle aspiration is not the only tool that's utilized in aiding our decision making. There are other tools as well. Ultrasonography, of course, emerges as a very close partner of the fine needle aspiration. Why? Because it's usually always employed to guide a fine needle aspiration. So you do an ultrasound and an FNA in conjunction. Therein, you can get valuable information before sampling the lesion, as well as trying to make conclusions once you have the cytology report with you. These are, broadly speaking, the advantages of ultrasonography, and it can do a lot of things. And of course, these are all subjective. We'll talk a little bit more objective in ultrasonography, but do remember that we are primarily looking for microcalcifications, hypervascularity, irregular borders, and a tall rather than wide shape of a nodule. And that's something that's going to alert us to the possibility of it being something more than a benign thyroid nodule. Just like the Bethesda system in 2007 changed the way we look at FNA, the Thyroid system, which is an ultrasonography or radiology staging system, changed the way we look at things in 2009. It's a point-based system, and you summate points based on composition, echogenicity, shape, margin, and echo, and you eventually club it into a risk score. So these are the scores that we look at, and this is from the ACR white paper, which not only is dividing into thyroids 1 to 5, but it's also dividing it into what should be done in these patients. So remember, a lot of your radiologists might be using thyroids. Some of them would not be, and do encourage them to pick up that synoptic reporting template. Thyroids 1 and Thyroids 2 typically does not require further intervention, even in the form of doing an FNA. Remember, an ultrasound always precedes an FNA, whether or not it is done solely or whether it is done to guide an FNA. So, of course, if you have a Thyroids 1 and 2 nodule, you're perfectly well within your rights to actually not order an FNA at that time, unless the nodule is big and unless you're concerned about other factors. Thyroids 3, 4, and 5 increase the spectrum of suspicion of a thyroid nodule. And of course, in these cases, you end up doing an FNA for the most part. In our institution, we do Thyroids 3 and higher. We don't do Thyroids 1 and 2. And here you have the division, the way you have it. And of course, remember that on ultrasound, you can also pick up lymph nodes that are predictive of malignant involvement. Such a big advantage of ultrasound in our setting. As long as you have a high resolution ultrasound machine in your hospital, you will be able to ask your radiologist to provide valuable information, not just about the nodule, but about the lymph nodes as well. But we leave it at that because we're primarily focusing our current discussion on nodules. Remember that beyond FNA and ultrasound, the third test that is always done to evaluate a thyroid nodule is thyroid function tests. Either just a TSH or a full complement of thyroid function tests. Couple of things which need to be remembered is that if a patient is hyperthyroid, the chance of it being malignant is low. So there are some guidelines out there which do not recommend an FNA of a nodule which is associated with a hyperthyroid state. Even though data is emerging that you can have concomitant hyperthyroidism, hyperthyroid nodules, as well as malignancy in the same setting. So what we do at our center is we order the entire complement of T3, T4, and TSH. If clinically we have any symptoms about this thyroid states, we only order a TSH if there's a clinical euthyroid state, and we make our decision accordingly. If we have to do secondary screening, then we use a free T4 and an ultrasensitive TSH. That pretty much sums up most philosophies of thyroid function testing in the setting of a thyroid nodule, which so far does not have any dysthyroid symptoms. What about thyroid scans? A few years back, a lot of people used to order diagnostic thyroid scans for thyroid nodules. The role of that has actually grown much lesser because as the ultrasound machines have become more higher in resolution, as the site-specific radiology has really gained in terms of having a separate vertical for thyroids, and as pickup rates as well as synoptic reporting for FNAs has increased, the role of thyroid scans has decreased because they weren't really able to add too much information to us. A lot of older papers indicate that cold nodules ended up being benign and warm nodules ended up being malignant. And that really was an antithesis of what we've been trained in our residency. But remember that sometimes for counseling our patients, we might offer a diagnostic thyroid scan, especially if molecular testing is not an option, after the 3-test complement has already been done. So when you've done your thyroid function tests, when you've done your ultrasound and your FNA, and you're counseling your patients, because remember, what you're trying to rule out is a very, very high and a good prognosis disease. So when you talk to them, a lot of times the questions that you're going to get from your patients is there any other option? So besides molecular testing, yes, a whole body diagnostic thyroid scan with technetium pertechnate is an option. And most centers currently, including ours, would have that facility. But yes, we've been recommending less and less as time has gone on. So to summarize diagnostic thyroid scans, they are of limited value in the pre-treatment setting. They are sometimes used or used to be used to aid decision-making in follicular neoplasms when everything that you have ordered as a routine test has already been done and you want to stratify your decision further. But again, for the trainees, please remember that there is a big difference between a thyroid uptake scan with technetium 99 and a radioactive iodine uptake scan. A radioactive iodine uptake scan we'll be talking about shortly. It's essentially used to manage differentiated thyroid cancer, not to elucidate the risk status of a nodule. We'll just quickly brush through all this. There is a role for plain skyograms in benign for the above 2 reasons, and for cancer for the below reasons. By and large, you'll get it because any surgical candidate will typically require a pre-anesthetic screening. And sometimes you get a surprise like this. You get a miliary pattern in your X-ray, and even a small thyroid cancer can sometimes be widely metastatic. Having said that, you don't change your management of those patients, and we'll talk about that shortly. These patients are still surgically treated, but having said that, a skyogram might be able to give you some valuable clues. What is the role of cross-sectional imaging? It is of adjunctive value, as the Tata paper, as well as some other elegant studies from England have shown us. There is adjunctive value in imaging the thyroid and the cervical nodes, especially the central compartment. As you see at the image on the top, you're getting some calcification in the central compartment, which is just below the thyroid and would otherwise not get picked up. And equally importantly, it's to rule out locally advanced thyroid cancer. You want to rule out invasion of the larynx, of the trachea. Sometimes if the groove is completely infiltrated, you can counsel your patient preemptively about the involvement of the recurrent laryngeal nerve as well. And of course, esophageal invasion, strap and perichondral invasion, which really tell you that you're dealing with a worse actor than you would be in case you're dealing with a differentiated thyroid cancer, and which might actually be poorly differentiated or otherwise. So it will give you valuable clues. Having said that, we order CTs at our institution for T3 and T4 disease or suspect T3, T4 disease only. For T1 and T2 thyroid cancer, we typically don't order any radiology, which is cross-sectional. We only order an ultrasound. And an ultrasound gives us quite valuable information, including the lateral cervical lymph nodes. Our policy would be for us to manage the central compartment, not prophylactically, but only therapeutically. And that information can be easily gained even after a thyroidectomy. However, if you want to gain some information, if you have let's say a 3 centimeter nodule, which technically would be T2, but if it looks like it's not freely mobile off the trachea, then by all means, you get cross-sectional radiology, but in select subsets of patients, of course. A core biopsy, we are winding up our discussion on workup of a thyroid nodule. Remember that it's of great use currently, post-2007, when the Turin proposal came about. It offers valuable information in dedifferentiated and anaplastic thyroid cancer and also lymphoma. Remember that if you're doing a core biopsy, the main reason of doing that is not just to pick up the histology, but also to pick up immunohistochemistry. So we normally consider a core biopsy in poorly differentiated, undifferentiated cancers and lymphoma. And the reasons we have discussed, they're listed over here. You might need IHC, and you will really need to see which patient actually needs to be operated, either in terms of histology or in terms of tumor extent. So that's important to rule out. Remember that when you are doing a core biopsy on a thyroid nodule, you want to be absolutely sure that you don't really shoot into an area where you don't need to be. So there's new BART mission coaxial needles, again, without any relevant relationships. We've been using that. It has a 10 millimeter shoot, and we are able to use it with or without image guidance. Okay. So some special situations we'll talk about: multinodular thyroid and malignancy. Each nodule, remember, that is greater than 1 centimeter carries an independent risk of malignancy. So if you have a multinodular thyroid and you are inclined to observe that patient and the patient does not have compressive symptoms, then multiple nodules might require FNA. Remember that. If the likelihood of malignancy is low, then you aspirate the largest nodules or continue surveillance. What happens when you have a patient with a Bethesda 2 nodule and you've decided to keep the patient under follow-up and you want a long-term follow-up of these patients? Remember that when you have a Bethesda 2, all comers are essentially equal. So you want the ultrasound to be the determinant, or the ultrasound pattern to be the determinant of what you should do with these patients. Will you intervene or not? So it's dependent on risk stratification based on an ultrasound pattern. Let's say nodules which are Bethesda 2 but have TIRADS 4 or 5 patterns. Then in that case, you repeat the ultrasound and a guided FNA within a period of 12 months. This is a compendium of the guidelines, and pretty much this is our institutional philosophy as well. If the nodules have a low to intermediate suspicion, let's say a TIRADS 3 or bordering onto a TIRADS 4 nodule, then you repeat an ultrasound at 1 to 2 years. We talked about sonographic evidence of significant growth. So if there is 20% increase in at least 2 nodule dimensions, with a minimal increase of 2 millimeter or more than a 50% change in volume, the FNA can be repeated in that case. So sometimes you might want to order a short-term ultrasound and therein take a call based on that. So if you have nodules with a very low ultrasound pattern, let's say you've FNA'd a nodule, which was Bethesda 2, and now you have a scenario in which you're only getting a TIRADS 2 nodule. You might have been consigned to do an FNA, but currently an FNA is not required. At that time, you just do an ultrasound at about 24 months, at about 2 years. Remember that if any nodule has had a second Bethesda 2 result, there is absolutely no need, unless compressive symptoms develop, of follow-up with an ultrasound or with an FNA. So I hope that's clear, that Bethesda 2 nodules, which are the vast majority of what we see that we've decided to observe, have very different patterns of follow-up depending upon the ultrasound characteristics. We'll probably skip pregnancy and thyroid nodules unless someone wants to address that in questions. And we'll end with the role of a PET. And the first line is the most important one. There's no role of a PET in the initial diagnostic algorithm of thyroid nodules. In fact, even within the setting of cancer, the role of PET is quite limited and it's never utilized in isolation. Remember that sometimes small and simple is good. So a good sonologist and a good ultrasound machine will be able to offer you much more information and much more stratification of nodule compared to something like a PET scan. So no PET for routine evaluation of thyroid nodules. So did you want us to pause here and then probably take questions and then we can probably go ahead with this?
Sure, sir.
Okay, so let's take a few questions on thyroid nodules and I'll request Shri Harsha and Bhargav to tell us when we are ready for the next part, which is the extent of surgery in differentiated thyroid cancer, and then we'll move ahead. Maybe 5 or 10 minutes I think would be good.
Okay, sir. So the questions have come in, sir. So the first question is from Dr. Arjun Roy. That is, in case of incidentalomas, what is the role of FNAC required?
Yeah, so the incidentaloma depends on what is the modality for diagnosis of incidentaloma. If it is a PET incidentaloma, then you have to see if the uptake is diffuse or focal. In diffuse uptake and deranged TFTs, really no FNA is required. But if the uptake is focal on a PET, in that case, the risk of malignancy might be as high as 35%. So you want to be absolutely sure about what modality you're using. An incidentaloma can also be based, let's say you get an MRI cervical spine for cervical spondylosis and you end up getting a thyroid nodule. Please don't stage that nodule based on an MR. Just get an ultrasound. If it is a TIRADS 1 or a TIRADS 2 nodule, then there's no need for an FNA. But of course, if it's a high suspicion pattern ultrasound, then by all means, do the FNA and then manage the patient like we talked to you about.
So the next question is again from Dr. Arjun itself. In case of a papillary carcinoma thyroid in younger patients, nodule less than 2 centimeters, is it treatment for observation or hemithyroidectomy?
So we'll talk about it in the extent of surgery for differentiated thyroid cancer. Why don't we address any questions that we might have in the question box about nodules per se, and DTC questions we'll take, and if those questions still remain at the end of the presentation. How does that sound?
Okay, sir. Sure. The other question is by Dr. Nanorem. Is the role of biopsy in Bethesda 3 and 4?
Role of a biopsy in Bethesda 3 and 4. Okay, good question. Bethesda 3 and 4, remember, depending upon what you read, has between a 5% and a 25% risk of malignancy. If we are looking at Bethesda 3 and 4 nodules in isolation, let's look at 3 first and then 4 later. Remember, 3 is either AUS or FLUS, atopy of undetermined significance or follicular lesion of undetermined significance. Those are the patients that you might want to either make a cell block and talk to them about molecular testing, or you want to probably do a core biopsy upfront and do it. That is the only indication that I would think in my mind about a Bethesda 3. If you trust your cytopathologist and your radiologist has given you a concomitant picture, I would probably be more inclined to have a detailed discussion with the family and the caregivers about the benefits of doing a hemithyroidectomy upfront. Remember, a hemithyroidectomy in today's day and age with due emphasis to facial plastics and the application of the same is a safe and non-morbid procedure. So in our center, for the most part, we'll be offering a hemithyroidectomy to 3 and 4 nodules. However, if they're inclined to follow up, then we'll follow them up based on the pattern that we discussed, that every 4 to 6 months, we have to do an ultrasound. Having said that, I will always ask my sonologist to look at the neck nodes very carefully, because even small Bethesda 3 and 4 nodules, if they're actually harboring a cancer, might have significant cervical adenopathy, in which case I would intervene much earlier.
Okay, sir. The next question is by some unknown name is not displayed. Sometimes the FNAC shows as follicular lesions. Whether all these patients should be advised of surgery? I think she's asking for again the hemothyroid or the observation.
So I'm glad she asked that question, because we talked about Bethesda 3, but if you talk about Bethesda 4, that is where the role of genetic testing is lesser. It is a follicular neoplasm or suspicious for a follicular neoplasm. In this case, we typically tend to offer a hemithyroidectomy to our patients without offering ancillary testing. The reason why we do that is because follicular architecture and a follicular variant of papillary carcinoma, or whether or not you have a follicular carcinoma, you can't really reliably distinguish till you have the entire capsule and you're able to document capsular and vascular invasion. Till the time you can do that, you really would be in a situation where you'll be wondering what kind of disease does the patient have. So if the patient is follow-up compliant, you might decide, and if the patient is disinclined regarding surgery, you have to also decide why the patient is disinclined regarding surgery. Is it a young female, like the question initially asked? If it's a young female who has cosmetic concerns, remember there is the option of remote access thyroidectomy, and we'll be talking about it tomorrow. Also remember that in case the patient is declining surgery because of any other reasons, then it's tantamount upon us as experienced thyroid surgeons to make sure that we tell them that it is a safe surgery, and barring a scar, which can also be obviated these days, we will be able to give you a good outcome. So Bethesda 4, for the most part, is going to be treated with a hemithyroidectomy, or at least it's going to be offered to them. If not, a tailored management protocol can be made for them.
Okay, sir. So the next question is by Dr. Ravi Shankar. Do we repeat FNAC in Bethesda in case of a follow-up if there is no change in the size?
I'm sorry, repeat that question again, please.
Do we repeat FNAC in cases of lesions of Bethesda 2 in the follow-up if there is no change in the size?
No, but remember, size is only one criteria. We talked about the TIRAD staging. So if the TIRAD staging has had a significant change, let's say a TIRADS 2 has become a 3, I would not be that concerned. But if it becomes a TIRADS 4, then I would probably do a repeat FNA, even if there is going to be a Bethesda 2 nodule on the initial FNA. A change in size is only one criterion. Echogenicity and a lot of other factors that we talked about are also going to play a role. At that time, I would talk to my sonologist and try to keep the same sonologist between two ultrasounds. It's easier said than done, but it's always good to make a team, have an MDT where you can probably collaborate with one person so that they can see their own reports and also have a synoptic reporting template so that you have some uniformity between various radiologists also.
Okay, thank you, sir. So the next question is by Dr. Kinjal. He is asking to highlight about tennis syndrome and the role of patinate. Do you want to take this question now?
No, I'm sorry. Can you repeat that question again?
He is asking about you to highlight about the tennis syndrome.
Yeah, absolutely.
Syndrome and the role of patinate.
Yeah, it's a great question, but I think it will be better for all the attendees. And I hope Dr. Kinjal will stay with us till the end, because the tennis syndrome is best managed only once we have talked about the initial management of thyroid cancer. Would that be fair?
Okay, sir. So our next question is by Dr. Karthik. In case of Bethesda 5 of offering hemithyroidectomy, will you mind tilt towards total thyroidectomy in the first sitting only rather than opting for a completion thyroidectomy?
Okay, so good question. We've covered that. In Bethesda 5, there are 4 or 5 subcategories in which you can offer a total thyroidectomy. One is a larger tumor, and this is recommendation 25 of the ATA. A nodule more than 4 centimeters, marked atypia seen on biopsy. And remember, the reason that they are getting it is they're not plucking it out of the air. They have done a retrospective analysis of Bethesda 5s who underwent surgery and therein were found to have differentiated thyroid cancer. So if you have atypia, if you have a nodule more than 4 centimeter, patient preference is going to be very important in this subset. So you want to talk to them about the fact that, there is a 70% chance that you have cancer. There's a 30% chance that you might not have it. In our experience, a lot of patients are going to elect a total thyroidectomy upfront. Having said that, just 6 to 7 days back, I don't want to sound anecdotal, but just 6 to 7 days back, we operated on a Bethesda 5 and she turned out well, and she selected a hemithyroidectomy. There's a lot of retrospective regret in our patients in case they end up with a cancer and then they have to undergo a completion thyroidectomy again, especially if the nodule is more than 4 centimeters. So you want to be very, very careful and upfront in your counseling with them. In our experience, and I think the experience of most thyroid surgeons, I see Dr. Hari Bhakti in the audience, and I hope we'll have some comments from him also later. The majority of our patients, not a vast majority, but a sizable majority of our Bethesda 5 patients get a total thyroidectomy because you sit down with them and you talk to them about all those options. But yes, offer a hemithyroidectomy if there are no other high-risk features in Bethesda 5, and offer a total thyroidectomy if there are any of the high-risk features as outlined in the recommendations.
Okay, thank you, sir. Okay. So the next question is again by Dr. Kinjal. Do you prefer BRAF mutation testing in cases of Bethesda 3 and 4 nodules?
So BRAF testing was actually the first genetic test that came about in the early 2000s. Now we have more sensitive and specific tools which incorporate BRAF as one of the mutations that is tested for. Remember, the BRAF historically came about when we did not have widespread application of the Bethesda system and was indicated to differentiate between the so-called follicular adenoma and carcinoma, which is also why, alluding to one prior question, the term follicular lesion does not exist anymore. With time, BRAF, PPAR gamma, PAX8, and RED PTC, and a bunch of other mutations have been identified in differentiated thyroid cancer. And the role of BRAF in isolation is low. Having said that, if you ordered a BRAF in a Bethesda 3 or 4, you'd be well within your rights to do that because a significant minority of these patients have cancer. Having said that, please keep in mind the cost and resource constraints that come with it. We mentioned that during the presentation. It is fairly expensive and it's fairly time consuming. In a country like ours, you'd be able to do a few patients hemithyroidectomy for what it costs to get a BRAF testing done. So do consider it, keep it on the table, especially with patients where you can't really get anywhere despite detailed counseling and the index testing. Like I said, we've done genetic testing in about 3 or 4 patients the last 5 years since it became more widely available. And we are an organization that does about 200 thyroids a year and probably follows about the same amount of thyroids every year. So be very careful about offering genetic testing because it does have its caveats. And it doesn't really push your sensitivity and specificity to 100. It still only results in a few point increase in your sensitivity specificity. But if you have a patient who needs that option, by all means do consider because it's now available in India. It's outsourced, but the sample collection can be done over here.
So the next question is a kind of a case presentation, case capsule kind of a thing by Dr. Sujan. He has a 68-year-old female with euthyroid status with thyroid 3 and MNG, which is size of 3.5 centimeters.
Okay.
USG FNAC from dominant nodule is Bethesda 3 with dysarrhythmia seizures. How would you approach?
So it's a 68-year-old female with a 3.5 centimeter dominant nodule within a multinodular goiter, which is Bethesda 3 on FNA, right?
Yeah.
Remember, one slide mentioned a multinodular thyroid as every nodule harboring an independent risk of malignancy. What I would look at is, besides the sonographic pattern, you said thyroid 3, right?
Yes, sir.
I would also look at the opposite side and see what the thyroids on the opposite nodules is. If the opposite side is absolutely pristine, and if it's a Bethesda 3 in a 68-year-old female, I would tend to offer her, because it's 3.5 centimeters, with our life expectancy being higher than usual, I would anticipate that this patient might have some globus or some compressive symptoms directly attributable to the nodule. I'd offer her at least a hemithyroidectomy, but my decision on extent of surgery will probably be gauged also by the opposite side. Let's say the opposite side also has the Bethesda 3. This is a patient I might consider for an FNA of the opposite side also. If the opposite side also shows up as a Bethesda 3 or 4, then a 68-year-old female, I don't know if she's about her comorbidity status, but in that case, in a limited setting, I'd offer a total thyroidectomy. But if the opposite side is clear, I'll offer a hemithyroidectomy.
Sir, but complicating your approach, there are two comorbidities. One is dysarrhythmia and seizures. So how would you go about now?
No, you're talking about
the same patient. The same patient, she has a comorbidity, she has a dysarrhythmia and the seizure. So would you still go for surgery?
It's also dependent. A lot of our patient population these days has the so-called modern epidemics. Okay, so if the dysarrhythmias are well controlled by a cardiologist and have been so for a while, if the patient has not had any active ictal episodes or seizure episodes for the last few years and is stable on anti-epileptic medication, I would probably let my neuroanesthetist and my cardiologist take a call along with me. Remember, just like we are very synoptic with thyroids and Bethesda, the cardiac people are also very sacrosanct with regard to the RCRI, and we follow the ACS-NSQIP index for deciding surgical risk also. A hemithyroidectomy in the routine setting, of course, I'd not consider her for remote access at all. She's 68 years old, and you want the surgery to be expeditious. It's not going to take more than half an hour, 45 minutes. So I'd probably let my medical specialist take the call along with me. However, if I think there is a significant risk of any intraoperative or perioperative complications, then, as we have already discussed, we'd hold off. A Bethesda 3 nodule has to be subjected to a repeat ultrasound, if not an FNA. And if there is significant growth in the nodule, in that case, you can, yes, put it on a follow-up. But like I said, if the patient is not comorbid, I'd offer surgery. If the patient is comorbid, then that opens up another algorithm in which you'll involve multiple decision makers to help come at a conclusion.
Okay, sir. So the next question is, what is your opinion in hemithyroidectomy for follicular lesion with unknown significance and frozen section for a completion thyroidectomy? Or you will wait for a final HP to show that confirmatory lesion?
Yeah, that's a good question. And, we've addressed that in meetings, in publications over the last 10 or 15 years. We have already known that that the frozen section is able to change management in only 15 out of 1,000, which is about 1.5% of patients who historically had a follicular lesion. The follicular lesion now, retrospectively staging per Bethesda, was Bethesda 4. So Bethesda 4's less than 2% of patients who changed your approach based on a frozen, which on a cost-benefit analysis is really not favorable. Which is why most experienced thyroid surgery proponents have moved away from using frozen section for nodule assessment. The problem also is that when you subject it to frozen section, there is, and our pathologists tell us that, I'm sure the opinion would be shared by at least some more experienced head neck proponents. The problem is that you violate the capsule to some extent. So you can't really pick up that minimally invasive follicular carcinoma or the NIFTP or something else. So as an institutional policy and based on our understanding of literature, we don't use frozen section for primary evaluation of the thyroid. We only use it for cervical lymph nodes in the central compartment or the lateral compartment in case we think they are borderline.
Okay, thank you, sir. Next, an interesting question by Dr. Joshna.
Should we move? Okay, yeah.
There are still a couple of questions, sir. We will take them and we'll end it here. So I request all the listeners to end the question session here. Well, rest of the questions will be taken up at the end. So last question is, how sensitive is Thyroids or Bethesda in recurrent nodule in case of a treated case of DTC?
So tell me again, Thyroids and Bethesda in recurrent DTC.
Yeah.
So, the Thyroids and the Bethesda staging have been designed for initial management or initial assessment of a thyroid nodule. When you talk about recurrent DTC, any nodule that you see is going to be considered with the highest index of suspicion, regardless of risk stratification. Remember, we are not talking about thyroid residual here. Yes, there is, if an experienced thyroid surgeon has done it, usually you don't face the problem of thyroid residual. But if you have any nodule that you are seeing in a patient with recurrent DTC, you really have to put all the pros and cons together. By all means, if it is FNA-able, sometimes in a fibroscarred thyroid bed, it might not be FNA-able either. But if it's picking up radioactive iodine in a focal manner within the nodule, you typically be tending to think that it does represent recurrent cancer. That does not apply to remnant thyroid parenchyma though. So yes, you'd still ask for a thyroid stage. Yes, you would still ask for Bethesda in a recurrent nodule in a setting of recurrent DTC. Having said that, you will also complement that information with a few more tools in your armamentarium, including a radioactive iodine scan, including a CT. I would always get a CT in this case because sometimes you're able to get a little bit of necrosis inside, thereby indicating that you might have some disease over there. And of course, thyroglobulin, because now you're dealing with a tumor which has a fairly sensitive biochemical marker. So you'd probably do all of those and take a decision accordingly, and that's something we have to talk about still, right?
Okay, sir. Sir, you want to take a last two questions?
Yeah, sure. Go ahead. Like you guys tell me whatever you say.
I
just hope we are okay on time because it's already.
From our side, it's fine, sir. We can continue.
Yeah, absolutely. Just take the call. Just let me know when you want me to start. Yes.
Yeah, sure. So the question from Dr. Pokhralal. Non-invasive follicular thyroid neoplasm with papillary-like nuclear features.
Yes.
How does this change Bethesda risk for malignancy?
So that's a great question. It's not been studied in a high level of evidence set. The only scenarios where NIFTP has been studied with regard to Bethesda has been in the retrospective setting and in a single institution setting. Having said that, the policy of NIFTP still remains similar. If you had an NIFTP and you did a hemithyroidectomy and the opposite side is okay, you can follow that patient. But yes, I'd follow him a little more assiduously. I'd follow that patient with 4 to 6 monthly ultrasounds and FNAs of any nodules that might subsequently develop. Bethesda, remember, is essentially a prospective stage. It's not going to be used retrospectively to make a call on a patient who's already been diagnosed as an NIFTP on histopathology. So histopathology has already been your benchmark in telling you, and this is post the JAMA paper, of course, that the patient has NIFTP. And yes, every subsequent nodule should get a Bethesda stage, but that might or might not play into your eventual decision making. Does that make sense?
Okay.
You have to consider the nodule on its own merits in the setting of NIFTP, because we're just dealing with a disease which has such good prognosis. So the next thing we're going to be talking about is the extent of thyroidectomy in cancer. Remember, we've talked about nodules already, and we will talk about cancer, shifting gears, because it's interesting how a lot of questions have been about cancer primarily. So we'll talk a little bit more about that. Remember that this will focus on management of the primary in thyroid cancer. We're not talking about neck so far. We'll probably take questions in the neck. Remember that there are multiple concerning symptoms. If you see a central neck mass and a lateral neck mass, that's usually a sine qua non of thyroid cancer, even though you have to prove it, of course. There are multiple symptoms that will alert you to the diagnosis of cancer. And once you pick up a cancer, you have to stage it. And we know that thyroid cancer is the only one where age plays a role in staging. There were multiple prognostic criteria that have been formulated over the last few decades, and these are a few of them. Eventually, of course, we have the ATA, and this is what a lot of us currently follow. And even though a lot of ATA risk groups lend themselves to retrospective staging, we divide them into low risk, intermediate, and high risk patients, and there is also a very low risk group in ATA now. It's interesting how the figure on the left indicates Western data. A lot of their patients are papillaries with a significant minority of follicular, and together DTC constitutes about 95% of their patients. But on the right, I look at a study from Amrita, which actually tells you that the number of papillary thyroid cancer patients are actually lower in our country, and the male-female ratio might be slightly skewed as well. This is data from my institution. This is something we looked at in 2013 after seeing that Amrita in the South was reporting something different, and whether we have something different either. So we found the results to be oddly similar to the situation with our South Indian colleagues. Papillary forms about 63%. This is a data set of about 270 total thyroidectomy patients done for differentiated thyroid cancer. Follicular was a significant minority again, but in total, they were only about 80%. When we looked at poorly and undifferentiated and medullary, they comprised a significant minority as well. And what's interesting is this was Games criteria, but based on that, high risk constituted the highest subgroup of patients when we retrospectively staged them using the Games criteria, the MSKCC criteria. So risk grouping, high. And this might have a corollary with the fact that we're probably seeing less DTC, and that's a great tool for us potentially looking at the role of other carcinogens. Moving on, this is what we know. A patient with a low risk tumor is the one which is younger, is female, small in size, low grade, no extrathyroidal extension or metastasis, and eventually these patients behave very well. The 20-year overall survival on MSKCC data shows 100% 20-year overall survival, and we're looking at them over 20 years. That's significant. You flip the picture, and the high-risk group really is the bad actor. And of course, there's an intermediate risk in between, which is something that we will discuss because that is the one where most of the controversy exists currently. Remember, we are talking about treatment of the primary, and the old method of treatment about a total thyroidectomy and radioactive iodine ablation has undergone a complete paradigm shift. Now you do risk stratified management. We'll talk about size and how it impacts the extent of surgery. The thing that changed everything for this was Carl Billimoria's paper. They looked at more than 50,000 patients and said that any tumor more than 1 centimeter should get a total thyroidectomy. The reason for that was that they said that there's a higher risk of recurrence and a higher risk of thyroid cancer mortality. Now remember that it had multiple disadvantages or limitations of the Billimoria paper, including the fact that it is a CL database drawn system. But again, moving on, since Billimoria, there have been multiple authors who have studied this. Notably, one paper by Adam in 2014, following Billimoria's paper about 7 years prior. It looked at an 18-year analysis of the National Cancer Database in the US and said that tumor size alone is a questionable indication, even though it hinted at 2 centimeter being a potential cutoff. So, in a patient who is low risk with a small intraglandular unifocal, well lateralized. Please pay emphasis to all of these. A patient is low risk based on our stratification, which is, of course, the pre-operative risk stratification, because that's what we have before deciding the extent of surgery. A small, which means less than 4 centimeters for sure, and depending upon your interpretation of literature, anywhere from 1 to 4 centimeter. Intraglandular, which does not have any extra capsular extension through the thyroid capsule or any extra thyroidal extension. Unifocal with a pristine opposite lobe and a well lateralized tumor, which is not going past the isthmus, and to some extent, some authors say not even involving the superior pole. This tumor would be tackled with a hemithyroidectomy. I think there's no controversy on that. The only controversy exists in terms of how much size plays a role. So risk stratification pretty much indicates all low-risk patients are candidates for hemithyroidectomy, and it's your philosophy and your interpretation of literature how you choose to treat them. Remember, there are other factors also. Contralateral thyroid nodules in a proven DTC case will typically be managed with a total thyroidectomy. This is an ATA recommendation, so we're taking near total out of it. Total thyroidectomy is the only surgery that's currently considered. If a patient has lymph node or distant metastasis, you'll always do a total thyroidectomy. And of course, the indications at the bottom are relative, and they've become relative over time. About 20 years back, from the data that we used to review, most of these patients used to get a total thyroidectomy. Yes, these are proven etiological factors for DTC, but again, it's a relative indication as to whether you do a total thyroidectomy in an older patient, a patient who has a first-degree relative, and a patient with a personal history of radiation therapy. Also, with radiation safety norms being better than what they've been, let's say a few decades earlier, you don't really get the fourth line here. You don't really get too many patients with personal history of radiation. But continuing with risk stratification, any high-risk tumor in all age groups with METs and gross extrathyroidal extension will receive a total thyroidectomy with or without extensions, and we'll talk about extensions at the end of this presentation. Remember that proven DTC with any contralateral nodule, irrespective of primary size, will usually get a total thyroidectomy. And the reason for that is that an FNA is reliably sensitive, but not necessarily specific in picking up a contralateral focus. So that's pretty much the norm. If you're doing, if you're committed to a hemithyroidectomy on one side and a patient has a contralateral nodule and you're proven DTC on one side, you will typically do a total thyroidectomy, because at the end of the day, this disease is a multicentric disease. If you have nodal metastasis, then again, it's fairly clear. You do a total thyroidectomy and you do the appropriate neck dissection. So if you have ipsilateral lateral cervical disease, you do a total thyroidectomy, a central compartment, and a lateral level 2 through 5. If you have bilateral central lymph nodes with no lateral nodes, you do bilateral central compartment. If you have bilateral lateral, then you do the whole hog. You do bilateral central compartment, bilateral lateral compartment. Again, age plays an important role in staging, may not necessarily play as big a role when you talk about surgical extent. Another relative indication is younger patients and older patients who tend to offer a total thyroidectomy irrespective of size. And that's again dependent on older data. We know that younger patients have a longer lifespan, but remember, you'll also be consigning them to a lifelong thyroid hormone supplementation. So that has to be taken with its benefits and risks. And there are other factors. We've talked about these. Distant metastasis always get a total thyroidectomy. And we talked about radiation exposure already. Remember now that there is also the circumstance of referral or a histological surprise. The referral is to the left. A patient who undergoes a hemithyroidectomy at an outside center and subsequently comes to your center, and the pathology is DTC. And the second scenario is if a patient had, let's say, to extend the questions that have been asked to us in the last session, if you had a Bethesda 3 and you did a hemithyroidectomy and you had a malignant final pathology, how do we tackle these patients? And remember that lobar ablation, as has been advocated by one of our champion authors from India, Dr. C.S. Bal, based on the evidence that we have, Sir has been instrumental in getting it within the guidelines. But for the most part, for teaching purposes, lobar ablation is not recommended in lieu of completion thyroidectomy in a patient who would have otherwise required total thyroidectomy to begin with, because of the following reasons. You have lack of strong efficacy data in higher risk populations. Multiple low dose therapies are needed. Up to 32% patients need multiple low dose therapies. And of course, we're in India, where the number of radiation therapy centers, radioactive iodine centers are only 167 based on BARC. A single high dose therapy comes with cost and morbidity. Surgical complication rates are lower in experienced hands. There is physician diversity. And of course, we are low resource, high volume. which is why completion thyroidectomy becomes the standard of care in this patient population. So remember, the purpose of this slide is just to tell you that even though there are some proponents for ablating the entire lobe on the opposite side in a patient with a histological surprise scenario, by and large, it is not supported by higher quality evidence. Yes, the only study that we have, the only high-level study that we have comes from our subcontinent. We're proud about that. Having said that, in a patient who would otherwise require a total thyroidectomy or would have retrospectively is managed with this protocol. This is an important question because a lot of our trainees, our fellows, they ask us very often that a patient came with a 2 centimeter focus and underwent a hemithyroidectomy. The opposite side is absolutely fine and what to do. Remember that this algorithm pretty much simplifies it all in terms of primary treatment, which we are discussing. If you are in any of those categories on the top, where a tumor is more than 4 centimeters, you have positive resection margins, ETE on final pathology, macroscopic multifocal disease, nodal metastasis, by any chance, let's say you had a patient come to you who underwent something called a community thyroidectomy and a nodal sampling. If the node is positive, for the most part, you'll have to do a completion thyroidectomy because that patient is likely to require radioactive iodine. In all of these scenarios, you'll typically complete the thyroidectomy and perform neck dissections as indicated. However, if a patient has a tumor 1 to 4 centimeters in diameter or lymphatic invasion, in that case, you have an option, which is a lower category of following active surveillance. And we've already said that levothyroxine therapy for nodules is not recommended, but for DTC, it has very different indications. So we'll talk about that shortly. Completion thyroidectomy would be recommended in a lot of authors' books. But again, if you go by a lot of our Western colleagues, they did not offer completion thyroidectomy in low-risk disease when the disease was, let's say, as much as 4 centimeters. And of course, in the bottom group, you do active surveillance alone. So in a papillary microcarcinoma with an opposite lobe that is normal, you want to make sure that you keep the TSH low and you follow those patients. When you do a thyroidectomy, whether or not it's per primer, whether or not it's recurrent, remember the purpose of doing a thyroidectomy is to completely remove the gross thyroid tissue. So a subtotal thyroidectomy does not exist in current day literature or in current day practice. A near total thyroidectomy by and large also does not exist. Remember that your thyroidectomy has to be extracapsular. Remember that you want to focus on areas where you tend to leave thyroid tissue behind, which is the superior pole, pyramidal lobe, lower cricoid border, ligament of Berry, and the like. You always want to distinguish your parathyroids, and we'll talk about that separately, from level 6 fat and lymph nodes and preserve all inferior thyroid artery branches. You already know that in per primum thyroidectomy, the lateral tubercle of Zucker candle is a reliable landmark because the recurrent laryngeal nerve is medial in nearly 100% of individuals. That does not apply to recurrent cases though. And of course, if the lobe is already been removed, then you can't use that as a landmark. So you need to familiarize yourself with a lot of landmarks, not just that. When you're doing a per primum thyroidectomy, however, it's a beneficial landmark. You avoid thermal damage to the recurrent laryngeal nerve. And of course, we can talk about penumbra of all energy instruments. Anticipate variant anatomy. As you see in this, you'll typically find 2, 3, or sometimes even more branches, ramifications, the answer of Galen, and other variations while you do a routine thyroidectomy. And the superior laryngeal nerve, again, depends on your philosophy, but you might not necessarily identify it. But if you are dissecting cranial to the upper border of superior pole, you have to be careful about it. Our institutional philosophy is that if the dissection of the superior pole goes cranial to the superior border of the cricothyroid muscle, we will always look for this for the nerve, for the superior laryngeal nerve, the external branch. In case it is fairly low, and in case the cricothyroid is well above the superior pole, in that case, we might decide not to look for it because it's a sensitive nerve, and sometimes you don't really want to separate the muscle fibers to do it because the delicate voice analysis have shown that it might have an impact. And something that people forget, and it's a basic question for all the trainees and the young practicing oncologists, after you complete a thyroidectomy, you always palpate for pathological lymph. Okay? So some basic points that I wanted to highlight, especially for the trainees, in terms of per primum thyroidectomy. Now, we'll shift focus to invasive thyroid cancer. Remember that we are talking about this management of primary thyroid cancer. The discussion for nodes will be separate. Remember that in invasive thyroid cancer, the easiest ones are the ones most commonly involved. Incorporating the strap muscle is something which can be easily done. And how you incorporate that? You isolate your area, superior and inferior to it, and here you're using a harmonic to just get a cuff under it, and the parathyroid is below you, and therein you get your strap muscles out. Of course, remember that if you're including sternohyoid in the resection, you want to specifically ask your pathologist to look for invasion outside of the thyroid, because you want them to document extrathyroidal extension. Therein, the tumor becomes high risk. Trachea and esophagus involvement over time in this select group of patients will affect survival. However, you should know that involvement of strap muscle, the recurrent laryngeal nerve, as well as the larynx involvement does not affect survival. And that's data set from some institutions, just a few hundred patients. So again, it's difficult to draw conclusions, but it kind of makes sense that when you have trachea and esophageal involvement, it's essentially like upper aerodigestive tract disease. So therein, the survival outcomes might directly be impacted by the extent of resection, which may be fairly morbid on its own. When we look at extent of involvement of thyroid cancer, this is what we see. The trachea is involved in a significant proportion of patients. And we already know that the esophagus, the recurrent laryngeal nerve, and the carotids, of course, in a small minority, because the adventitia is just so strong. We'd encourage you to look at the Shin classification, which categorizes these patients as stage 1, 2, 3, and 4. And we'll talk to you about how to manage all of them. Straps is fairly straightforward. Esophagus is by and large managed with an extramucosal shave, if feasible, of course. Recurrent laryngeal nerve, we can probably put in the discussion. But the only thing we'll talk about currently in terms of invasive thyroid cancer, also in the interest of time and also to allow for a stimulating discussion, is trachea. So if you have stage 1 invasion, for the most part, you'd be able to get away by doing a laryngotracheal shave. This is an upside down picture. So you get some gel foam that's protecting the area of the recurrent laryngeal nerve and the thyroid beds. But for the most part, you do a subperichondrial or a perichondrial shave. That's essentially the area where there is only abutment without any invasion. When you have stage 2 tracheal invasion, where it is not intraluminal, but it is extending just up to it and cartilage is involved, our choice is to do a vascularized subhyoid flap and following a wedge resection if technically feasible. A lot of these patients might need a concertina excision, might not need a full tracheal resection and end-to-end anastomosis. However, when you're looking at intraluminal disease like this, in that case, the only option for stage 3 and stage 4 tracheal invasion is a tracheal resection and end-to-end anastomosis. And of course, you have the subsequent precautions that you have to take. The Grillo stitch, if that's an institutional philosophy, making sure that you try to avoid a tracheotomy, using a stent only if you're very concerned about tracheomalacia. Most of our tracheal resections, end-to-end anastomosis, will be managed without a stent or a tracheotomy, because the area of involvement by differentiated thyroid cancer is usually quite focal. But you have to select these patients very carefully, and we can probably discuss it a little more as we go on. Remember that when there is superior mediastinal extension, you have options. If it's just up to the level of the thoracic inlet and the bottom part of level 6, which you're seeing in the innominate, in that case, you might want to just do a transcervical approach. You might consider dividing the ipsilateral sternoclavicular ligament. There's very elegant literature by thoracic surgeons on when to divide the sternum, a limited sternotomy, a full sternotomy. And that is, of course, outside of the purview of this. But invasive thyroid cancer, for the most part, something that is subaortic will typically not be managed surgically. Those are unfortunately the select subset which will not do that well. But if you have superior mediastinal extension, you have these options of a limited sternotomy, or doing an intracervical dissection or a transcervical, or doing a limited exposure like a sternoclavicular ligament division. Remember that when you're dissecting your level 6, sometimes you might get a high riding innominate artery, and it's very important to not be subinnominate, because you'll hit the innominate vein first. So be mindful of all the anatomical variations that you can get. This is a rare patient which we don't see every now and then, but this is a patient who comes to you gasping with bilateral cord palsy, and you have to take a call on a patient in terms of giving her a respectable end, in terms of making sure that she does not asphyxiate. So very rarely, maybe once in 2 years, with posterior mediastinal extension and this kind of disease, we'll take this patient up, end up with a mediastinal tracheotomy, and have the kind of disease managed to the extent of getting to the azygos, getting your CTVS surgeons on board, and getting a vascularized flap in there. Of course, 2 things to remember. This is something which you only want to do with very senior colleagues. Number 2, you want to counsel the patient that these patients cannot be rehabilitated in terms of voice. This lady survived for about 1.5 years before eventually succumbing to distant metastatic disease. And the last part, of course, is carotids, which are involved in 0 to 7% of patients with invasive thyroid cancer. Remember that carotid resections do not confer a survival benefit in squamous cell cancer. But in thyroid cancer, we are selective about doing these. This is a reverse saphenous vein graft over a shunt in the left picture that you're seeing. And this was from an invasive thyroid cancer. The thyroid component and the cervical metastases have been peeled off, and the rest of the resection will happen afterwards. And you always want to cover this kind of reconstruction, vascular reconstruction, with some kind of vascularized muscle. Usually the pectoralis major is used. So talking about invasive cancer and initial management of DTC, remember that you have to stratify all thyroid cancer patients so that you can individualize their therapy regimen. The majority of low-risk tumors will be adequately treated with a hemithyroidectomy, and of course, it's your individual philosophy. Many indications, like we've discussed, will mandate a total thyroidectomy in initial management of DTC. And remember, we're not talking about adjuvant. We're only talking about the initial management. Talking about invasive thyroid cancer, the intent in extended thyroid resections for invasive thyroid cancer is definitive in the majority. So yes, if you take these patients up, you have to be certain that you're giving them an R0 resection. Remember, a narrow margin resection also confers improvement in survival in thyroid cancer. So you don't really have to be dogmatic about a wider margin in thyroid cancer. As long as you can get all microscopic disease out, that would be your aim. And last but not the least, you want your management to be evidence-based and definitive. Just like in all head and neck cancers, just like in all cancers in general, and all disease processes in general, differentiated thyroid cancer follows the same norm. So you want to follow the same as you go on. Great. So we're done with this part as well. Bhargav, can you hear us?
Yes, sir. We can hear you.
Great. So we can start taking questions.
Yeah. So first question is from Dr. Nina Ida. Some surgeons still doing berry picking in M1, metastasis 1 DTC cases with N1B, and debulking thyroidectomy for locally advanced thyroid cases. What is your opinion on these?
So if I understand correctly, the question pertains to locally advanced thyroid cancer, which is already metastatic and during the initial management. Now, this is the subgroup of patients which we deemed were resectable, right? Yes, and we went ahead and did less than a complete neck dissection, right?
Yep.
Yeah. So see, as far as lateral neck is concerned, you're not really adding much morbidity by doing a 2 through 5 over and above doing a berry picking. The crux of your concern should be the area where the disease has actually become invasive, because you will, for the most part, have to do an aerodigestive tract excision. Our philosophy would just be to look at the disease as a sum of its parts. We know that the disease has a very high incidence of occult micrometastasis in the neck. If you're really doing an extended thyroid resection, you don't want to revisit that bed again and again. You really want to rely on your adjuvant therapy components to be able to sanitize the disease and give you a good survival. I would really not want to see a neck recurrence in a patient where the micrometastases are already involved to such extent. And also conversely, I'd want my radioactive iodine to go and act on the areas of the distant metastasis, which might not be possible if we leave nodal tissue behind. Having said that, if I'm committed to doing a resection for invasive thyroid cancer or locally advanced thyroid cancer, I would go ahead and do a full neck dissection if the neck were involved. Remember that there is no role of prophylactic neck dissection. Some tumors, especially non-papillary, could have invasive thyroid cancer in the absence of neck nodes. In that case, yes, by all means, don't address the neck. But if you have neck positivity, you have to do the entire complement of the neck dissection.
Another interesting question by Dr. Kunjal Acharya. How do you predict for a non-recurrent laryngeal nerve when you don't have a nerve motor during a surgery?
Okay. So we have nerve monitoring on our topics tomorrow. So I'd encourage the person who asked the question to attend tomorrow as well. But if you're looking at non-recurrent on the right side, we're looking at a nerve that is coursing more horizontally. We talked briefly about relying on all of your landmarks to make sure that you're able to identify all the structures that you need to. Remember that a structure that courses transversely much more often than a non-recurrent nerve is going to be the inferior thyroid artery. You want to rely on whatever landmarks you have learned and mastered during the course of your experience in thyroid surgery, your Jones triangles and your Beer's triangles and otherwise. Identify all the landmarks and don't ligate anything that comes transversely to avoid the possibility of a rare non-recurrent laryngeal nerve on the right side. Having said that, also remember that you might be dealing with a situation where you might have very extensive thyroid disease in that setting also. So if you have low volume thyroid disease, you actually have to be more cognizant of a non-recurrent compared to high volume disease, because you'll be more cognizant of that posteriorly located nodule. Remember that your principles of anatomical localization of a non-recurrent remain exactly the same as a recurrent. Normally, the philosophy of most of us thyroid surgeons for per primum thyroidectomies is identifying the recurrent laryngeal nerve in the middle third. If you're trying to find it in the middle third, in that case, a non-recurrent is essentially, if I were to put it that way, waiting to be found. A non-recurrent, by and large, courses through the mid portion of the neck, and you will be able to identify it in the vast majority of instances. And bottom line would be, don't take any transversely leading structure till you're absolutely certain where it leads to. Much more important than in transverse structures than a recurrent laryngeal nerve, which might be non-recurrent, would be the inferior thyroid. A blind cross-clamping of the inferior thyroid will have much more deleterious complications for your patient in the long run, including the possibility of permanent hypoparathyroidism. You don't want to go down that route. So yes, rely on your anatomical landmarks. Make sure that you have a sound knowledge of variations, and the non-recurrent should be easy to find. Having said that, I've seen a non-recurrent right side about 3 times in my entire career, not that often.
Thank you, sir. So the next question is again by Dr. Nina Ira. If you have a N1B case, will you do a prophylactic ipsilateral central compartment clearance? And is there a bronchoscopy routinely done to rule out the Shin's classification of 3 and 4 preoperatively?
So, great question. Like I said, our institutional philosophy to avoid an invasive procedure like a bronchoscopy, I'll answer the second part first, would be to do a CT. If you do good cross-sectional imaging and you ask for fine cuts through the trachea, essentially you're looking at the areas of abutment of the thyroid gland to the trachea. To stratify the Shin's classification, you don't need a bronchoscopy every single time. But what we do is we use the CT as an initial screening tool. If we use the CT as initial screening, we'll be able to get fine cuts through the entire area of tracheal abutment with the thyroid gland. If at any point of time we think there's an intraluminal bulge, which is extramucosal, which is Shin 3, or an intramucosal intraluminal bulge, which is Shin 4, we'd be able to stratify it further with a tracheoscopy. So, of course, not a bronchoscopy, but a tracheoscopy. The advantage of a tracheoscopy is that in addition to isolating and localizing the exact segment that needs to be removed, you'll also be able to see tracheomalacia, which is very difficult to pick up even on a real-time MR or a CT. Cartilage dissolution is not very easily picked up. The reason why this would happen is if a patient has an invasive cancer in the setting of a multinodular goiter, the multinodular disease might have caused some mild tracheomalacia, and the invasive thyroid cancer would have caused intraluminal invasion, thereby making your anastomosis patency rates difficult. The corollary that we follow is simple. Get cross-sectional imaging for all T3 and T4 DTCs, largely for central compartment lymph nodes. We always get it done if the thyroid cancer is not mobile of the trachea. And if we find anything on the CT, then we do a tracheoscopy, not a full bronchoscopy. That's not required. But yes, you do a tracheoscopy till the carina so that you can get an idea of the total length of the trachea to see how much you'll be able to get together with an intralaryngeal release or with a suprahyoid release or with metasternal release. Coming to the first part, I think the question that she asked was about prophylactic neck dissection in a patient with N1.
N1B. N1B.
And
Lateral compartment neck.
So there's no controversy in that. N1B disease needs an ipsilateral central compartment clearance because barring an occasional tumor that has gone directly from the superior pole to the upper deep cervical lymph nodes, for the most part, the pathway of spread of lymphatics is going to be through the ipsilateral central compartment. So whenever you have to address lateral cervical nodal disease with a 2 through 5 neck dissection, you always address the ipsilateral central compartment also. To that effect, it is not a prophylactic central compartment dissection, it's actually a therapeutic central compartment dissection.
Okay. The next question made a little bit of a chat in our chat room, sir, is by Dr. Avinash. How many tracheal ring resections can be closed primarily?
Yeah, so That's a question we used to get in our Viva OC, right?
Yeah.
So remember, the trachea is like an incomplete concertina. The trachea will have complete rings, and it will also have incomplete rings. It will have Y's facing your way, and it will have Y's facing the other way. So the question is relevant, but yes, the question is something which is the answer to which is a little more complex than you'd otherwise think. So what we do is, remember that you don't need a centimeter on each side of the trachea for a resection. We know that for invasive thyroid cancer, a narrow margin resection or an R0 resection is all we need. We don't really need that dogma of a margin. So you figure out the point not of abutment, but of the extent of tracheal involvement. If that factor is to the tune of 20 to 25% with the denominator being the total length of the trachea, you're going to be good. Which means that if you look at the adult male and female trachea, they're going to have dimensions between 11 and 16 centimeters up to the level of the cranium. If the trachea and the larynx have not been previously violated, and if the patient has not been, let's say, has not received any other treatment to the neck in the past for any other disease, then you typically be able to get about 3 to 4 centimeters close primarily as a direct function of the 25% that we talked about. The old dogma also of the 2 centimeter release once you do suprahyoid and the 1 to 2 centimeter with the mediastinum is something that's to be taken with a pinch of salt. A lot of times, and that's for the younger colleagues out there, a lot of times you end up with a tracheal defect and you're scratching your head in the middle of the surgery that, I will not be able to get it closed. But remember, a lot of these patients are going to get the sternomental stitch. A lot of these patients are not going to have a tracheotomy, thereby facilitating the hyperflexion if you don't have any spine anomalies. So what might be an extended a defect in full neck extension of about 5 centimeters might actually be about 3.5 centimeters. And you need about 2.5 to 3 weeks of immobilization of that anastomosis before you're able to do that. So I'd encourage you to look at maybe 1/4 of the entire tracheal length, and that would typically translate to about 4 to 5 tracheal lengths.
Okay, sir. So our next question is by one of our budding fellows, Dr. Achut. So he's asking, do you recommend 2 to 4 or 2 to 5 levels neck dissection in a routine neck dissection? And what are the special circumstances where you will consider level 1 dissection also?
Okay, so it's fairly standard also. Historically, the MRND3, when it was first developed, and I'm giving you a little bit of a historical perspective, was popularized. It initially did not gain much prominence for squamous cell carcinoma. The only cases it was being used for was differentiated thyroid cancer, because that's the only disease that they thought had good enough prognosis to merit preservation of all non-lymphatic structures. Over time, we've realized that philosophy to be wrong, but I'm using it as a historical correlate to actually let you know that level 1 used to be dissected routinely. It's over time on a retrospective analysis, one from Sloan Kettering, one from Europe, I'll have to probably scratch my head on the institution again. They realized that less than 5% of specimens actually harbored level 1 disease. So level 1 also has morbidity. We don't really want to cause any inadvertent xerostomia. We don't want the ramus mandibularis to even become paresed for a short-term period. It's a significant functional morbidity in the small minority of patients that it happens. So level 1 is only addressed if level 1 is directly involved. Our philosophy is, if there is any supradigastric disease, we will address level 1B. Level 1A would be managed pretty much the same way. As regards level 5, remember there's an anatomical continuum between the first echelon, which is 6 to 3 and 4, and 3 and 4 to 5. So historical perspectives on these specimens showed that the incidence of level 5 involvement was much higher than 20%, which actually is your cutoff for addressing occult disease also. So for the most part, for lateral nodal disease that is positive and clinically manifest, you will do level 2, 3, 4, and 5. And yes, the spinal accessory is a morbidity, but remember, you should be able to preserve it in the vast majority of cases. And some shoulder physiotherapy should be able to obviate that morbidity. Always preserve the branch to the SCM so that it does not end up being like a fibrous contracted band. But lateral cervical neck disease, the literature is pretty clear on that now, and standard textbooks have followed the same 2, 3, 4, and 5. But of course, to address the prior question and to reinforce it, a level 6 dissection has to be done at the same time, which is the central compartment ipsilateral.
Okay, sir. Sir, there are a couple of questions related to the surgical aspect of this one, which I'm not asking them right away by Dr. Kanika and other person. So
Okay. No, but
I
go
will
ahead.
keep it
Just
once the
decide,
surgery.
yeah, just decide whichever ones you think are most relevant to the audience and we'll answer
Yeah,
all of them.
now I'm going to put up only questions which are relevant to our topic.
Sure.
So, in which patients can we avoid elective central compartment neck dissection?
Okay. So, I am a believer in therapeutic central compartment neck dissection. The prophylactic central compartment neck dissection is something that used to be talked amongst a lot of us about 5 or 6 years back. And over time, guidelines, evidence, and pretty much whatever we practice on a contemporary scenario is pointing a little bit far away from an elective central compartment or a prophylactic. The reasons are many. The only advantage that it offers are persistent athyroglobulinemia, and that's been shown in multiple studies. But you have to trade off with a risk of temporary hypocalcemia. Now, some people might say that transient hypocalcemia is not a functional surrogate, but in the age of outpatient thyroidectomy, transient hypocalcemia actually becomes a big problem. All of us have had patients where transient hypocalcemia really was a big bother to them, much more than the surgical scar, sometimes even much more than the fear of a cancer, which otherwise has a very good prognosis. So, central compartment neck dissection has also probably been pushed down in favor by the guideline agencies. If you look at ATA guidelines 2009, recommendation 27, it was a strong recommendation with a moderate quality evidence. But that recommendation has now become recommendation 36 in ATA 2016, where it is a weak recommendation with low quality evidence. So in our setting, and actually I'd like to send the message out, it's controversial still, but I think the jury is pretty much clearing itself a little over the last few years. We've pretty much managed to develop some kind of a consensus. Prophylactic central compartment neck dissection, which used to be advocated for T3 and T4 disease, is something which is no longer practiced. The only scenarios in which we do it are if there is significant extrathyroidal extension. If there is significant ETE, then in that case, you know that that anatomical continuum is broken and you will feel much more comfortable sanitizing the central compartment. Having said that, just like we mentioned in our principles of thyroidectomy, once you've removed the thyroid, you always carefully inspect the central compartment, whether it is a T1 tumor, whether it is a T2 tumor. So careful inspection, and remember, this is where frozen section also comes in. If you're certain that what you're looking at after removing the thyroid is not a thyrothymic rest, but actually might represent a central compartment node, by all means, here is where you can use the frozen section analysis to actually send across a test and see if it harbors thyroid tissue. That's all you need to know. If it's positive, then you have an ad lib conversion to a therapeutic, because that's no longer prophylactic now, right? Always counsel and consent your patient for a possible central compartment dissection, whether or not you're dealing with a T1, T2, T3, or T4 tumor. That would be our philosophy.
I think we'll continue with the rest of the seminar because some people are leaving. So we'll take the and the questions are mixed. They're pouring in like some other subjects also, other aspects of the surgery and everything. We'll continue and finish off today's presentation, and then we'll take all the questions at a time.
Okay, so we'll talk about another surgical aspect, which I believe had been told to me by the organizers. That was probably going to be the vast majority of all of our attendees. So we'll focus on that. Remember, we've talked about thyroid nodule. We've talked about initial management of DTC, and I'm glad that we were able to address a lot of questions about the neck. So one thing that is very close to all of our hearts as thyroid surgeons is the parathyroids. They say that the first 100 thyroids that you do are a nerve, and every subsequent thyroid you do is going to be about the parathyroids in this case. Can you guys hear me? I'm just getting some signals over here, so I just want to make sure.
Yes, sir, we are able to hear you.
Okay, great. So we'll talk about parathyroid preservation and thyroid surgery, and I think we'll be able to have a good discussion on this because that's something that unites all of us, however experience, regardless of experience, regardless of training level. We are concerned about the parathyroids, and we want to make sure that we preserve them every single time. So during the course of these 10 minutes odd, we'll talk about anatomy and variations. We'll talk about how to identify parathyroid glands. We'll talk about handling them during a thyroidectomy and handling them during a central compartment neck dissection. The reoperations of the central compartment part we'll skip for tomorrow. because tomorrow we'll be talking about recurrent DTC, and we'll talk about some specific surgical situations as well as how to handle a devascularized or an amputated parathyroid. And we've kept it sufficiently basic. And the first thing that you start with being basic is by reviewing the texts. So when you start looking at texts, you'll realize how little our texts have to offer. These are some otolaryngology texts which really don't really cover any technical perspectives of parathyroid preservation. With due respect to all the leaders who've written them, it's just something that's been a little bit ignored in terms of being able to offer us what we believe should have been a very important point. We turn to the oncology texts, and the situation does not really get that better. We look at all our leading oncology texts, and the only thing that's been covered is terminal branches of the inferior thyroid artery have to be individually clipped, and that's a very important point. But parathyroid identification is something that's not focused on as much as all of us as thyroid surgeons would like. What do we know about basic parathyroid anatomy? We know that inferior parathyroids are usually ventral and superior are usually dorsal. That's what we know. That's the usual. But what vexes us sometimes is that the inferior parathyroids especially are very variable in their location. The superior parathyroid glands are more constant in location. They're usually found to be midway along the posterior border of the thyroid gland, though they could be higher. The inferior pair are located in multiple places within the thyroid sheath, inferior thyroid arteries, and sometimes in the mediastinum as well. So you want to make sure that you identify them also in a setting where they might be confused with level 6 fat or with surrounding lymph nodes. Remember that when you identify them, you want to identify them with 3 criteria: by their location, by their color, and by the landmarks. Remember that no imaging technique can correctly pinpoint the location of a normal parathyroid gland. The decision is essentially clinical, which is where all the romanticism and all the variations come in. In the picture on the left, you can see the inferior as being ventral and the superior being dorsal, just hiding a little bit behind cricothyroid. But the picture is not always as classical. In the picture on the right, you're seeing them in a different location, even though they've been preserved, and they required a little bit more of skeletonization than would otherwise be. So remember, you can't rely on any ancillary tools to help you what a parathyroid is. You have to rely on your eye and the fine interface and the distinction between what appears like a parathyroid, what is like a lymph node, and which is otherwise. We already talked about the variable location of inferior being ventral and superior being dorsal, but color is also an important surrogate, especially an unviolated parathyroid. Some teachers tell us that when you dissect a parathyroid or when you dissect close to it, if you find some degree of discoloration, you can fairly be sure that it's going to be a parathyroid. But having said that, we need some more objective criteria than that. The color has been variably described as tan, caramel, yellow, brown. Having said that, it is usually distinguishable in younger individuals. It will have a slightly darker color, and if you look carefully, you'll find a leash of blood vessels that is typically going inside it, something that you will not find in fat, but you'll find in lymph nodes and other ones. Also, they are more scaphoid compared to lymph nodes that are typically more spherical or more oblong, so that helps us a little bit also. And sometimes, especially for the superior, which is enveloped in some level 6 fat, you might be able to rove it. It's a roving sign. The parathyroid might be able to be mobile within that packet of fat which contains that small vascular leash. Remember that when you talk about parathyroid preservation during thyroidectomy, there are a few things that you have to talk about. You ID the parathyroids utilizing the normal landmarks, and the landmarks, quite interestingly, are located in conjunction with variable structures to begin with. We never use vascular landmarks to identify parathyroids, which means the superior and inferior thyroid arteries, but we rely on a complex interplay of our experience so far, and we also rely on the relationship of the parathyroids with the recurrent laryngeal nerve, which is also a variable structure, to really help us, which is why the variation comes in. So just imagine, this is a smorgasbord of variations. We are using a variable anatomy structure to identify another structure which is even more variable in anatomy. And that is where the challenge comes in. But for the most part, we ID parathyroids at roughly the midpoint of the dissection. You don't really want to remove the entire thyroid gland and then say where the parathyroids are. The inferior would typically lend itself to identification much earlier compared to the superior, which is going to be identified only once you do that. And then we'll run you through a little bit of how you would find a parathyroid during a thyroidectomy. And essentially, the identification starts at the level of the strap. This is a montage of various videos, which helps us identify, and as we continue our steps of doing a thyroidectomy, and this would be the middle thyroid, and then the superior would lend us otherwise. Remember that the second golden rule for parathyroids would be that you do blunt dissection, as we are seeing currently, only at the medial aspect of the parathyroids. Don't really go towards the lateral aspect of the thyroid disease. Go where the disease mandates. Don't go just because you have to identify the structures upfront. This is the inferior pole, and you found the inferior parathyroid in this location, in this particular case, and that is just below the nodule, and you want to be careful. Like we said, blunt dissection at the lateral border. Here, there's some variation or some duality between where the nodule ends and where the parathyroid begins. So you're putting a clip over there so you can make sure that you identify that. Here again, there's a small vascular sheath between a thyrothymic rest, a type 2, as well as the parathyroid gland. Also remember that when you divide your sternothyroid, you want to divide it ad lib. And again, it's an institutional philosophy. Sometimes you would and sometimes you would not. But when you divide it, sometimes you'll just see the superior parathyroid come into view. Once you do that, you go a little more laterally, and herein you are seeing the EBSLN nicely showing itself to you in a patient. We identified this because it was going higher than the cricothyroid. And sometimes you will be in this vascular niche where a lot of structures would really not lend themselves to easy identification. You want to do an extracapsular thyroidectomy every single time, and you want to individually ligate the ITA branches, as you're seeing in this part of the video, at capsule entry. You don't really want to be more lateral, and therein you bipolar the capsule and make sure that you identify all the anatomical structures that come with it. We already talked about anticipating anatomical variations, especially in inferior glands. So these 5 golden rules really help us identify our parathyroids and also make sure that your neurological structures are identified. And that's still when the thyroid is in situ. So you don't start looking for them when the thyroid is out. That's the point that we are trying to make. Remember that when you're handling a parathyroid during a central compartment neck dissection, the philosophy is different because the thyroid has already been removed. The first thing that we do is to identify the common carotid artery, because that's going to be the very constant lateral limit of your central compartment clearance. You tag your parathyroids first as soon as you find them. Here you see one parathyroid has been tagged and it's on the lateral aspect. And we'll talk about the role of intraoperative cytology shortly over here. And you're seeing a leash of inferior thyroid artery that's coming up. You preserve your arborizations of the inferior thyroid artery, keeping all the variations in mind. And herein, when you're carefully dissecting this area, you'll be able to find not just the recurrent laryngeal, which has already been identified during the thyroidectomy, but also these fine leashes of nerves and blood vessels that are individually supplying the parathyroid. We already talked about the conundrum when you sometimes see a structure which, despite all the reliance on landmarks and color and location, you still might not be able to find or reliably distinguish a parathyroid from level 6 fat or from a lymph node. In that case, you take a small sliver from a candidate, label it as a superior parathyroid candidate or an inferior parathyroid candidate, and therein go. So, and once you identify your parathyroids, then you can do this finger dissection, because then you're certain that on the ipsilateral side, you've already found the 2 parathyroids, and therein you come. Remember, we talked about using color change as a guide. So you use your color change as a guide every single time you're dissecting a structure. And remember, don't be very aggressive on that structure which has changed color. And we'll talk about that as well. If you devascularize, how we're going to do it. Remember that if a neck dissection is required, it will be very counterproductive for us to take the thyrocervical trunk and still leave the inferior thyroid artery, because that would have absolutely no bearing. You need to be able to identify the thyrocervical trunk, especially in cases of low level 4 disease. So those are our 4 rules for parathyroid handling during CCND. We'll talk about a redo CCND tomorrow, like we discussed, because that would be appropriate once we've talked about the adjuvant therapy of initially diagnosed thyroid cancer. What about some special situations? This admittedly is a big problem. How do you identify parathyroids in goiters as big as these? I'd be the first one to tell you that it's a very difficult situation, even in very experienced hands. The parathyroid location and landmarks may be grossly distorted. Just remember that you follow the same principles, and the color actually ends up being a great guide in patients like this. Resist the urge to what we would call crudely as sweeping and delivering. Don't sweep and deliver. make sure that you keep on working assiduously on the lateral aspect of the thyroid. Sometimes you will find the inferior parathyroid especially as being encountered much more superficially because you cannot predict nodule growth pattern. Some nodules might have grown superficial in between or below the parathyroid. In these cases, the superior thyroid, the parathyroids are your bulwark. You really want to make sure that your superior parathyroids are well vascularized and in position. And the superior thyroid artery also has a lateral branch, the Halsted and Evans branch, which will be supplying the superior parathyroid also. Some branches of the inferior thyroid artery can also be preserved. But for large goiters, like I said, I think your main guards are going to be your superior parathyroids. And of course, the role of reimplantation comes in. In thyroglossal duct carcinoma, some people are concerned that they might not be able to preserve parathyroids the way they would be in a standard thyroidectomy. But that is actually not true. The converse is true. Yes, you'll get all these lobulated extensions like a type 3 thyrothymic rest, but for the most part, this disease is midline and the principles of parathyroid preservation will remain unchanged. Of course, there is an issue of the bilateral central compartment neck dissection. I think some of you have already alluded to it during your questions. The biggest problem with a bilateral CCND is going to be hypoparathyroidism. Ideally not permanent, just transient, but we'll talk about how we address the situation, especially in the setting where vascularity is compromised. We talked about superior medial standard dissections already, and in that case, we really have to skeletonize the recurrent laryngeal nerves all the way down to the innominate, and therein find the parathyroids in location with that. We wanted this to be a treatise on surgery, so we've deliberately stayed away from a lot of randomized trials or retrospective analysis, but this is something which would be beneficial. Once we do a bilateral central compartment neck dissection, we know that transient hypocalcemia in experienced operators, and look at the numbers are fairly good, they're all in the hundreds. Transient hypocalcemia is pretty much a given in these patients. And permanent hypocalcemia is something which you encounter less frequently. But do remember that for bilateral CCNDs or central compartment clearances, parathyroid preservation as a question or as an issue becomes even much more important. Therein comes the role of reimplantation. We talked about large thyroids potentially requiring it. We talked about color change being a guide during your surgery for all this. But this is what you typically see in a patient who has discoloration. So you see a persistently discolored structure that looks like the parathyroid. It's the inferior parathyroid in this case, and it's lying right on top of the recurrent laryngeal nerve. Warm irrigation and small lance with a beaver blade will help relieve some of the venous congestion. But if it remains permanently discolored, then the algorithm that we follow is on the left. You confirm the parathyroid tissue by sending just a small sliver while the parathyroid is still perfusing. Sending a sliver while the parathyroid is perfusing has two advantages. It could potentially relieve venous congestion by giving you a bigger front for venous exsanguination. And also, in case the color improves, you would probably want to leave it in situ as opposed to otherwise. Remember, a completely discolored thyroid, the parathyroid would better be reimplanted, but a mild discoloration of the parathyroid would actually be okay as long as it stays stable throughout the course of the surgery. If you have amputated the parathyroid, which you might find during the surgery, which you might find during the course of a specimen examination, and that's why examining the specimen after a thyroidectomy is extremely important, you immerse it in cold saline till reimplantation and still send the same sliver that we talked about. You create a suitable superficial vascularized muscle pocket. And remember that if you've done a bilateral central compartment neck dissection or an ipsilateral lateral neck dissection, you want to select the opposite side because the SCM on the operated side of a 2 through 5 would be significantly devascularized. So you want to make sure that you choose the SCM which is better vascularized. We use the SCM typically. We moved away from forearm reimplantation, which mostly has role in endocrine surgery, but not as much in surgery for DTC. In thinner patients like we get in pretty much across the country, you'd be able to palpate even if you've reimplanted something which might have small fragments of potential disease. Whenever we reimplant, we section the parathyroid into thin slivers and we reinsert it into the muscle pocket that we made. You always mark the implantation site with a suture or clip that you have not used that much so far. So yes, if you've not used too many clips, then you use titanium clips. If you've not used any silk or any suture, then you use something, but you try to use non-absorbable so that you're able to address it. Remember, you're dealing with an indolent disease that could come back a while later or might need addressal a little bit later. But remember, these patients will never become hypercalcemic because what you're implanting is native parathyroid. There's enough data. There's enough data that parathyroid reimplantation works. Very elegant articles. One of these has been highlighted over here, but there's also another very good article in the World Journal of Surgery, which tells you that transplanted or reimplanted parathyroid glands will work in patients, and they've compared one transplanted versus two, and therein. So we know that reimplantation does have a role to play in the management of our DTC patients. We looked at our own rates of parathyroid preservation over a 2-year period. This was by a single surgeon in 2000, from the middle of 2013 to 2015, when we had our forum on thyroid cancer. Our incidence of transient hypoparathyroidism following total thyroidectomy with the techniques or with measures that we discussed was quite acceptable, or what we thought at least comparable with published literature. Once we did a unilateral central compartment clearance with any procedure, which is a total thyroidectomy, essentially, our rates went up to 6.4%. And since it was transient, it still compared okay. But see, here is where the problem begins. Once you do a bilateral central compartment clearance, and once you have a patient who's had a total thyroidectomy and bilateral CCND, the chance of transient hypocalcemia secondary to hypoparathyroidism increased to 19.2%. This is the subset of patients who will not have their calcium revert to normal within a few weeks of the surgery. They will take a couple of weeks till the parathyroid really starts firing, and these are the patients who really need to take care of. So the top two subsets, we are still discharging the same day. We are following outpatient thyroidectomy. Again, it's a very subjective surgeon-directed decision. But as a rule, as part of our departmental protocols, we are admitting each one of the bilateral CCNDs that we're operating on. If we look at mean specimen volume, we try to look at factors which might have explained these percentages, even though they were well comparable with world literature. Our vocal fold paresis rates remained okay, less than 1%, which you would expect. Subjective scar satisfaction was good. We thought that probably one reason why we're finding that is because Punjab has a fair bit of multinodular thyroid. Our mean specimen volume was quite high, about 1.5 to 2 times of what you would find. And this is in DTC, remember, this is not in multinodular goiter. So we were getting a slightly larger thyroid per philosophy on parathyroid preservation. The ID begins with incision. Always rely on our anatomical landmarks, location and color, whatever little we have. We know we are dealing with variant anatomy and we're relying on variable structures to further identify that variant anatomy. But just make sure you're fastidious and assiduous every single time. A parathyroid handling in day 1 of your first year of your career is probably going to remain the same as day 1 of your 40th year in your career. So you have to be equally careful every single time, and you have to spend some time on that. Anticipate anatomical variations. Preserve not just the gland, but its vascularity. So ligate your inferior thyroid artery branches distally. Do not manipulate the lateral aspect of the parathyroids excessively. It's going to send your small vascular lesions into a spasm. So handle them on the medial aspect where the interface with the thyroid gland is going to be, while remaining extracapsular on the thyroid gland. Like we discussed just now, we admit our bilateral CCNDs, and of course, extensive neck dissections are admitted as part of protocol anyway. And we do a therapeutic central compartment clearance only because we believe that transient hypocalcemia is also not acceptable in the age of outpatient thyroidectomy. Otherwise, to address the prior question that was asked, we inspect the central compartment routinely and we sample ad lib. And whenever in doubt, always reimplant a parathyroid that you're not really sure about. Using this philosophy, we've been able to keep our rates comparable with most leading institutions of our size, of our volume. And parathyroid preservation really is the hallmark, or let's say the cornerstone of all thyroid surgery, which is going to be and I think that's probably going to remain here to stay. The techniques that have been highlighted for identification and selective venous sampling and everything have really had very variable results. We still don't have a gold standard technique. So, but in the meantime, be more clinical, be more cognizant, and be abreast of your variations of anatomy. Thank you.
So, if a tracheostomy has been done along with total thyroidectomy, do you take any further precautions in situations like suturing stoma to skin?
Yeah. So good question. And the answer for that is fairly simple. we don't want tracheal secretions to contaminate our thyroid bed on both sides. The thyroid bed, which has our parathyroids and our nerves over there. So what we do is we always, if we are doing a total thyroidectomy with a tracheostomy, we will convert it into a single Bjork flap, either superiorly or inferiorly based. We will do a permanent stoma. The permanent stoma will have to be surgically reversed as and when the indication for tracheostomy is done. In our setting, because our rates of RLN palsy, as would be anticipated from a thyroidectomy practice, are fairly low, the only indication for doing a tracheostomy along with a total thyroidectomy would be tracheomalacia secondary to very large multinodular goiter or long-standing thyroid compression from a cancer without tracheal invasion. In that case, we will always suture the stoma to the skin. We'll make sure that the closure is watertight. And once the tracheomalacia has resolved, which it will usually either with Montgomery tube placement or with some environmental factors, there's enough data for that also, that there's some secondary fibrosis once we expose the trachea to the outside atmosphere. Once the causative reason for the tracheomalacia is gone, then we reverse the tracheostomy surgically, which can be done in the outpatient setting. And it's usually done over about 15 minutes under local anesthesia.
Okay, sir. Thank you. So the next question is, what is your view on prophylactic central neck dissection in DTC in case of iatrogenic esophageal rupture?
In case of a what rupture?
Iatrogenic esophageal rupture. If there is a surgical complication, I think you want to ask invasive disease or node, or in that situation where you rupture esophagus.
So see, if you are dealing with a tumor that has esophageal invasion, by all means, you have to skeletonize the entire recurrent laryngeal nerve from the point of entry where the cricothyroid joint to the point of entry into the thoracic inlet or till the point where the innominate artery is. Why do you need that? Because to be able to clear the disease from the esophagus, you need to, if you're lucky, you'll get ahead with, will get by an extramucosal shape. But we have had circumstances where we had to open up the esophagus, do an esophagotomy, a mucosal resection, even do a flap sometimes. So to do that kind of procedure or to clear the esophagus of disease, whether or not it's an iatrogenic rupture or whether it's a planned resection, you will need all the exposure that you can get. In which case, you will do a central compartment dissection, but that will more be for access purposes than a prophylactic. I already mentioned the fact that the only indication in which I would do a central compartment neck in the absence of nodal disease is gross extrathyroidal extension. And esophageal involvement actually ends up being in the category of gross extrathyroid extension. So yes, that central compartment will need to be sanitized.
Thank you, sir. So next question is by Dr. Kinjal again. In case of a FTC, presence with distal metastasis, would you like to use recombinant TSS to reduce the delay in radioiodine ablation?
So, the FDA approval, I think I could not hear the first sentence, but you said metastatic differentiated thyroid cancer.
FTC, familial follicular thyroid cancer. Metastatic follicular thyroid cancer.
Metastatic follicular thyroid cancer. Okay. So you want to, see, if you're dealing with follicular thyroid cancer, it has been an FDA approved indication for using recombinant TSH as a protocol. Having said that, a lot of authors have expressed their concern about using it in manifest distant metastatic disease because they don't really want the TSH to be in the hundreds, because we know that TSH is trophic to differentiated thyroid cancer. It stimulates the growth of that. Some studies have been done on the safety profile. In our case, the practice in which I'm working currently, that question is probably largely redundant because recombinant TSH is not covered by any insurance company. And a very small minority of our patients actually end up getting recombinant TSH. The question would be, if a patient were affording and if it were covered and if some empanelment agencies cover it, would I consider using it? Maybe not in distant metastatic disease because I share the same concerns as TSH being trophic. The only indications in which we have used recombinant TSH in the few patients that we've done are patients who have intolerable symptoms with endogenous thyroid hormone withdrawal. When they have intolerable symptoms the last time around, we would typically go ahead and give them recombinant TSH. on day 0.9 mg/m, day 1 and day 2. And after that, the TSH is adequately stimulated for us to do the routine scintigraphic testing. So that's the only setting in which we've explored it. FDA approval is not does not correlate with your clinical practice. You might your interpretation of literature might be different. We don't use it in distant metastatic disease. And also, from our country's standpoint, we have to conserve the resources also. A lot of our patients pay out of pocket, and for them to be, and remember, there's an entity of radioactive iodine refractory disease in which tyrosine kinase inhibitors are really quite prohibitive in terms of cost, and they are also not covered by insurance. So I would want to reserve those resources for therapeutic modalities as opposed to really doing a fast track algorithm for distant metastatic disease.
Okay, sir. So next question is by Dr. Joshna. Is in case of singers, would you take a special precaution for superior laryngeal nerve along with the RLN?
So we outlined our philosophy for the SLN. Whenever you outline the thyroid gland and its dimensions and what you're supposed to address, if the superior pole goes above the cranial border of the cricothyroid, we always identify the superior laryngeal nerve, the external branch, and before starting the dissection of the superior pole, because we really want to be mindful about the hernia 2B. Having said that, singers would probably not mandate any difference or a change in our philosophy. But yes, if we are talking about superior pole dissection, a lot of time our fellows would be doing it. A lot of time our junior consultants would be doing it. If I were a professional voice user, I'd probably be more sacrosanct about making sure that someone more senior does it, because they really rely on their voice for their occupation, and they are the ones who are able to pick up a small change in the pitch or the tensile strength of their voice. The interesting question, however, is would you use nerve monitoring more often in patients who are singers and everything? And remember that the nerve monitoring that is mostly used is intermittent IONM. It's not CIONM, but one of the advantages that have been postulated about continuous IONM has been that since it can also, through continuous vagal stimulation, it can monitor the SLN. Therein, it has more applicability in professional voice users. But we can probably talk about that tomorrow when we talk a little bit more. But currently, no change in philosophy in our institution.
Okay, sir. And one more question on tracheomalacia, sir. Do you want to take this tomorrow? In case of a tracheomalacia,
we'll take surgical questions today. I think surgical questions we can.
Yeah, yes. Sir. Because that's today's topic. I have been because you didn't mention it, we did not discuss it. But anyway, we'll take the questions, sir.
Yeah, absolutely. All questions. Yeah.
Okay. In case of tracheomalacia, what is your take on tracheal stenting preoperatively?
See, tracheal stenting preoperatively and postoperatively is going to be a call essentially made on how much do you think the tracheomalacia is. In fact, I've covered it in part, but I'm glad someone asked the question. If you do an awake tracheoscopy after anesthetizing the mucosa of the larynx, you can still get a very good idea about tracheomalacia by seeing the tracheal give when you are in the trachea during a tracheoscopy. What that means is, if you use a 6 millimeter bronchoscope or even a tracheoscope and you apply negative pressure suction, usually only the posterior wall caves in because it's formed by the trachealis, and that's generally something that's not very stable. But if the C cartilage, if that starts caving in, that's a good subjective indicator of the fact how much tracheomalacia you're dealing with. Also, you'll be able to decide the segment, especially on an MR, where some degree of cartilage signal intensity might be apparent. We don't preoperatively stent it. The reason for that is that the decision for stenting a trachea with tracheomalacia is usually made at the time of the surgery. And since it's essentially an intraoperative decision, it does not add much to the morbidity of a patient by putting a Montgomery stent intraoperatively. And remember that even if you have to do it, your patients are well managed because they still have a capped button and they are managed pretty much the same way. So I don't think a preoperative stenting is going to add anything over and above what you do intraoperative.
Our next question is a little interesting, sir. Regarding AJCG staging, what is the significance of N0A stage?
I'm sorry, just repeat it again.
In new AJCG staging, what is the significance of N0A?
I'm not familiar with that. So I think your reader can probably, the person who asked the question can be more descriptive, and maybe we can take it up tomorrow.
Oh, okay, sir.
Yeah.
Just a second. Someone was asking on indocyanine green, utilization of indocyanine green in case of parathyroid surgery?
So, see, we talked about this at the end of the last parathyroid talk. Various dyes, selective venous sampling, indigo carmine, ICG have all been used. ICG has also had some very elegant literature in head and neck in terms of deciding about perforator flaps and the extent and the anatomy of thereof. Boston University has some very good guidelines for using it in head and neck surgery. One of the indications that have been explored is to assess the vascularity of the pharyngeal remnant after a laryngectomy to decide how much mucosa you can actually use as a scaffold. As regards parathyroid, we are really operating in a very, very vascular bed. And we know that the early phase of take-up is going to be across the thyroid and the parathyroid. It's only in the delayed phase that we are able to probably bring it down. Using ICG alone without a spy camera has been explored in parathyroid. We currently, since we're talking only about parathyroid surgery currently, the early and the delayed phases can be given a good indicator in terms of the system EV scan also, which has an early phase and which has a delayed phase. Therein, you at least get scintigraphic quantification of the parathyroid. A CT along with a MEB, a CT MEB per se, is something which has been added to add some more anatomical information to that. But ICG we've not used. I remember in the US during one of my fellowships, there was someone who was doing a candidate thesis on this, and I remember the results as not being very encouraging. However, remember that if you have to use ICG, it's essentially a selective localization in the delayed phase without any infrared cameras that are typically used along with ICG.
So next question is by Dr. Acharya. Do you think not dissecting lateral to RLN during a central neck dissection, especially during a prophylactic central neck dissection, will preserve parathyroid?
Well, at the philosophy sounds tempting, right? We already know that the lymph node packet is mostly concentrated in the inferomedial aspect of the central. So the nodal yield is much more inferomedial to the nerve compared to superolateral. Having said that, I would not espouse that as a standard. Also because we don't do prophylactic. If you're doing a complete central compartment neck dissection, you'll always be able to find the leash, which we showed you also, of the inferior thyroid artery, which is leading up to the superior parathyroid, especially in patients who don't have distorted anatomy from any prior intervention. You identify your ITA branches, preserve the putative parathyroids, send a sliver of those parathyroids that you think might or might not be for frozen section, and you'll pretty much be okay. As regards addressing it prophylactically and only doing the inferomedial part in prophylactic because we are concerned about the parathyroids, I would not agree with that. Just like there is no subtotal and near total thyroidectomy these days, there is also nothing like a half a central compartment neck dissection and a full central compartment dissection. So if you are committed to doing a central compartment clearance, barring a routine inspection and ad lib sampling, which you can do for frozen section, make sure that you've done a complete job. Also because there are prognostic criteria now for lymph nodal recurrence, you really don't want to revisit a central compartment which has already been dissected.
Okay. So the next question is again based on the same topic by Dr. Ratan Shetty. Do you incise the capsule of discolored parathyroid to distinguish between venous congestion and arterial insufficiency? Yeah,
so that's a good question. We hinted a little bit on that, and our protocol is very simple. It's clinical. Everyone can follow it. When you have something that looks like a discolored parathyroid, the first thing you do is some warm irrigation over that area because there might be some microclots that are probably subcapsular. Once you have gotten rid of that area and it still looks congested, we always incise the capsule. We use a small beaver blade, or you could use the tip of an 11 blade, and you let the exsanguination happen. Remember that if it is venous congestion, you'll know immediately because you'll have a small micro spurt of venous blood which will escape the parathyroid, and sometimes the color will improve. Having said that, it might be a combination of arterial insufficiency and venous insufficiency, which is why prevention is always better than cure. You should focus on the medial aspects of parathyroids. We should always make sure that ITA arporizations are paid attention to make sure that we don't end up having a situation where you have a combined insufficiency, which would be rare with experienced surgeons. So yes, we would incise the capsule, and if the color does not improve, I would send a sliver and therein keep the parathyroid or the candidate vascularized in the bed till I get the frozen report back, because sometimes there is a delayed improvement in color also.
So next question is by Dr. Pallavi. What is the role of thymectomy during central compartment clearance during DTC?
I think it's as simple as encountering a thymus where you did not intend to identify the thymus. Remember, the thymus is also a highly variable structure. You'll sometimes find it in front of the innominate artery. Sometimes you'll find it much below, in which you will not encounter because the innominate artery is going to be the inferior-most limit of level 6. And sometimes you'll actually encounter it coming up or pushing up a little bit superior above the thoracic inlet. If you find it, and if it compromises your exposure of all the limits of a central compartment neck dissection, and we'll talk about it tomorrow, we'll talk about redo central compartment. In that case, by all means, go ahead and take the thymus. It's not going to have much functional deficit. Also, it's going to help you by making sure that you have a more clean field of dissection. You're able to find the small branches of innominate vein, which again we'll talk about tomorrow, because sometimes the thymus hides the small tributaries of the innominate vein. Take the thymus that is in the way to your inferior limit of your level 6 dissection, but do no more. Of course, if you're doing a superior mediastinal dissection, either transcervically yourself or in conjunction with your CTVS colleagues, then the thymus is always taken and it really has no morbidity associated.
Yes, sir. The next question is by Dr. Nina Ira. Although we are doing always doing extracapsular thyroidectomy, would you consider to do subcapsular dissection on superior pole to prevent external branch of the superior laryngeal nerve, especially in cases when you are dealing with type 2B?
Yeah, so it's a good question, and again, it's been addressed in literature. What we do is, prior to identifying the medial branch of the superior thyroid pole, we'd also identify the lateral compartment, just lateral to the superior pedicle. You really are able to see the superior pole vessels coming up nicely or entering the thyroid parenchyma at a point where they are just breaching the capsule and going inside. I would recommend taking the superior pole vessels at that juncture. We've already outlined our philosophy about elective versus ad-lib identification of the superior laryngeal nerve, the external branch. And if I'm concerned that the superior pole is too close to the cricothyroid muscle, if it's going much higher than that, and if it's more medial, then in that case, I would not do my superior pole dissection till the time that I've identified the external branch. But yes, subcapsular dissection, we don't really recommend that, because that's exactly one of the locations just behind the superior pole where a lot of radioactive iodine uptake comes in, because people have cross-clamped that area or done subcapsular dissection over there. I don't think it's to be recommended. It will not have an impact on your survival, remember, but it will have an impact on your local regional recurrence or your peace of mind when you're scintigraphically following that disease. So be extracapsular, that would be my recommendation.
Okay, sir, just the last couple of questions.
Sure.
What do you think of vasa nervosum and RLN for identifying RLN?
That's a good question. And again, it's interesting. It's almost like someone got a sneak peek of what we're going to be discussing tomorrow. We will talk about vasa nervosum on the recurrent laryngeal nerve during recurrent thyroid cancer surgery. But for the most part, remember that the vasa would not be identified for identification. It will be identified for the most part to distinguish a nerve from another structure that's in the vicinity. Now, what other structures are in the vicinity which look similar? The internal thyroid artery, especially the main trunk, is going to have a fairly robust vasa vasorum also. So don't use the vasa nervorum for identification. But sometimes you feel just a little bit more secure because you know that the vasa nervosum is intact, and therein you know that the nerve is probably not going to go into neuropraxia. Having said that, it's not a literature supported thing. Use your landmarks to identify it. Don't rely on vasa nervosum, but if you have intact vasa nervosum, if you have it bleeding just a little bit at the end of the surgery, that's always a good sign that your nerve is well vascularized.
Okay, sir. Just simple question. What is the difference between prophylactic and therapeutic central neck dissection, in your opinion, or your experience, and your inspection of the CCD, central compartment?
It's a very practical question. But we'll answer it in one sentence each. A prophylactic central compartment neck dissection is because you're perceiving micrometastasis in the absence of manifest disease, and you're doing it mostly for T3 and T4 DTCs and some aggressive histologies, as used to be advocated earlier. A therapeutic central compartment dissection is a procedure that is done in the presence of clinico-radiologically manifest disease in the central compartment. The extent of prophylactic and therapeutic remain exactly the same. So remember that. We've already talked about it in the prior questions. The indications thereof have changed, especially over the last 8 or 9 years. For us to think that prophylactic central compartment dissection is something that's probably on the way out. But remember, if you find a frozen section positive node, or if you find a clinically manifest node during your surgery, which was not picked up earlier, it is no longer a prophylactic central compartment dissection. It is by all means a therapeutic, because you're clearing the disease, manifest disease, from the central compartment. As far as the sampling is concerned, sampling is something which is not analogous to berry picking, contrary to what people would say. Remember, berry picking used to be manifest nodes being plucked out. We never do that in a central compartment. The routine inspection and careful sampling of the central compartment is only tantamount to morphological characteristics, and all of them should be subjected to intraoperative cytology. And if it's positive, then we do a full central compartment dissection.
So the final question for today is that do you have any special protocol for hypocalcemia post-op?
So there is something called parathyroid stunning, in which we know that the parathyroids have been preserved, but the parathyroids are going to take some time to recover. There is another phenomenon called parathyroid splinting, in which you try to splint the action of the parathyroids by adding some exogenous compounds to make up for the parathyroid stunning. Now, we've done a study at our institution where we looked at uncomplicated thyroids without neck dissection, about 100 odd, benign as well as malignant. We did not use size as a criterion, where all 4 glands were identified. 4 glands identification was possible in greater than 90% of our patients. So remember that when you have all glands identified and you're fairly happy about the vascularity, you might not need to do any parathyroid splinting. However, we live in a time of outpatient thyroidectomy where a lot of patients will go home the same day. About 70 to 80% of our total thyroidectomies without a central compartment or without a lateral compartment go home the same day. We also know that hypocalcemia will manifest usually on the 2nd or the 3rd postoperative day, by which time the patient would have gone. So you have the choice of 2 philosophies. Okay, I'll tell you the first philosophy, which is described in literature, the inpatient philosophy, and I'll tell you the other one that we follow. The inpatient philosophy mandates that you keep the patient with you for a minimum of 3 days, test calcium every 12 hours for 3 days, and therein supplement calcium in case you think the patient is becoming symptomatic. We follow the second approach, which is the outpatient thyroidectomy approach. We do splint the parathyroids after total thyroidectomy or a higher procedure. We do 500 milligrams of calcium carbonate BD. The maximum that people have gone up to is TDS. Remember that if you have detectable parathyroid hormone, you don't need Rocaltrol in these patients. You just need to splint it with some calcium supplementation so that the patient does not become overtly or clinically symptomatic. Also, you could consider in outpatient parathyroids, if your organization has a rapid PTH assay, to get a rapid PTH done. What I do is, if I'm concerned that I've not found all 4 parathyroids, I would just do a PTH. If the PTH is detectable, in that case, we are fairly certain that everything would be okay. And so far, God willing, we've not found a single scenario in which we found 3 or higher parathyroids and was still undetectable. It never is. You go ahead and splint the parathyroid, keep the patient overnight if you really feel compelled to, and then send the patient home the next day. And follow that patient very carefully. Outpatient thyroidectomies, we follow a liaison protocol in which every 2 days the patient is called to ask for symptoms of hypocalcemia, because we know that about 3%, based on our data, 3% of our patients are going to still become hypocalcemic. Thank you everyone for attending, including the ones who've left. Thank you so much.